Ravi, are you there?
No. I am in ECR.
Okay, fine.
Go to share screen again.
I think Matthew Koshi, you have to ask to unmute.
Allow Zoom to close. Cancel. Go here, no, direct. It's not taking it, no. Go here. Of the desktop. Ask, is it coming?
No, it's not coming.
It's coming.
As of now, it's not coming. No. I'm able to see your face, but the presentation, I'm not able to see, ma'am.
It's not coming?
No, ma'am. I think Mac has an issue.
Hmm? Sondri,
Yes, ma'am.
go to the next speaker. I'll come back again.
Sure, ma'am.
Okay. Yeah.
So since we have some technical glitches, we'll move on to the next topic, which is going to be infectious keratitis. Dr. Namrita Sharma, professor in cornea, cataract and refractive services at Rajendra Prasad Center for Ophthalmic Sciences, All India Institute of Medical Science, New Delhi. She did her fellowship from Moorfields Eye Hospital in London. She's the honorary secretary for All India's Ophthalmic Society. She has numerous international awards to her credit, which includes lots. You can continue to read it for the entire day. She's currently also the secretary, Eye Bank Associations of India. She's a principal investigator in many multi-centric international FDA trials and numerous randomized controlled clinical trials. She is not able to join us. So what she has done is she has recorded the program and she has sent it to us. Can we have the team broadcasting it? About the infectious keratitis? Yeah.
Talking to you about latest armaments in the management of corneal ulcer, and there are no financial disclosures. And the latest armaments can be in the field of diagnostics, such as microbiology, imaging techniques, and therapeutics, such as newer drugs, newer methods of drug delivery, collagen cross-linking, and also use of adjuvants such as gene and spatch graft. Apart from the routine history taking and slit lamp evaluation, we do spectral domain anterior segment OCT is an important tool to monitor, diagnose, and follow up cases of microbial keratitis, especially posterior corneal abscesses, which may become difficult to monitor on slit lamp. Now, microbiology has undergone a sea change in the form of next generation sequencing and matrix assisted laser desorption and ionization, or MALDI, which is available to us now, apart from the routine staining that we did with gram stain, KOH, and for acid-fast bacilli, as well as cultures such as blood agar, dextrose agar, and other media. So next genome sequencing picks up the pathogens which have not grown. Determines the DNA sequence. The sequence of the gene is obtained and is matched with the software which contains the sequence of the various pathogens. And then pathogen identification, resistance, and virulence is obtained. MALDI laser desorption or ionization. So the sample culture is taken, is mixed with the matrix, and this is then metal plate is then introduced in the mass spectrometer, and it is bombarded with the various laser pulses. So there are dissolved and ionized molecules which travel up at a particular speed, and depending upon the travel of the speed, you do obtain various peaks on the graphs, and these are actually nothing but the signatures of the various microorganisms. Adenoviral keratoconjunctivitis, such as shown here, can be very difficult to treat, and you can have nuclear opacity, such as here in the center, which can scar. For detection of this, we have now rapid adeno detector, which is rapid antigen detection immunoassay, which detects 53 serotypes. The sensitivity is 88%, specificity 91%, and this is much faster and better than the PCR, which picks up the dead virus. Strongest steroid should be used for adenoviral keratoconjunctivitis. Topical povidone iodine with steroid is also shown to be extremely useful. And in recurrences, topical cyclosporin or topical tacrolimus can be tried. Topical HU-IFN beta is the new molecule for adenoviral keratoconjunctivitis. only tried anecdotally. In herpes keratitis, you can have epithelial herpes keratitis, stromal, necrotizing, or it can be double immune ring of Wesley. And this is the classical treatment, topical acyclovir, which is 1 week, and then 3 times for 21 days. For epithelial and stromal, you add pedacetate after 1 week, and for necrotizing and non-necrotizing stromal herpes keratitis, systemic acyclovir 400 milligram 5 times a day is added for about 3 weeks. Now, apart from topical acyclovir, topical ganciclovir 0.15% can be given. It is less toxic, better tolerated, safer, and can be also given in cases which are resistant to acyclovir. And oral valcyclovir can be given instead of oral acyclovir because 500 milligrams of valcyclovir once a day is as effective as 400 milligram of acyclovir twice a day. And so the compliance gets better because the dosing is decreased. Likewise, oral ganciclovir can also be given, especially in cases of CMV endothelitis. The dose is 1000 milligrams for 8 weeks, and acyclovir 400 milligram 5 times a day. For varicella zoster, oral acyclovir 800 milligram 5 times a day should be given to 10 to 14 days. But the new thing that is there is the live vaccine, Zostavax, which is used in more than 60 years of age. It decreases the incidence of zoster by half, the postherpetic neuralgia decreases by 66%, and the duration of protection is for 4 years. And for CMV endothelitis, again, it should be diagnosed more frequently. We often miss it, but it responds to systemic and topical ganciclovir with the use of topical steroids. As far as the bacterial keratitis is concerned, we continue to give fluoroquinolones. The new kid on the block is, and we are doing whether it compares therapy or not. These are our previous 2 studies with moxiflox and gateplox vis-a-vis combination therapy. And of course, specific antibiotics has to be given for specific organisms, and we are all aware of this in various situations that it has to be given. Resistance, both topically and systemically, is rising exponentially in the recent years. Our study has clearly shown fluoroquinolones, there is almost resistance in about 33% of the cases. So what we need to look at is new combination and formulations and increased use of antibiotics which we were not using earlier. So linezolid, colistin, imipenem have been tried in anecdotal reports. So this is a case which is tried with topical colistin, then with piperacillin and tazobactam for Pseudomonas keratitis. And how do you prevent resistance? So you use a very low dose or too short duration of antimicrobial usage would increase the antimicrobial resistance. So use the right antibiotics, do rapid tests, so use them quickly. And do not taper the antibiotics, but stop at the therapeutic dose. Now, coming to fungal keratitis, Confoscan is an important tool for diagnosis of, apart from the Acanthamoeba cysts and the trophozoites, and natamycin continues of choice for these. You can add systemic drug if the ulcer is large. And between oral voriconazole and ketoconazole in a RCT, we found that voriconazole was better in terms of serum concentration and tear film concentration. And we also have evaluated the role of intracameral and intracorneal agents. These are cases to show the same. And this is again case series of intrastromal voriconazole. Now, based on this publication, which is shown here, as well as all our studies that we have done, we arrived at topical, systemic, and targeted therapy protocol, which was again done in a prospective study. So when the ulcer size is small and the depth is also less, topical natamycin can be given. If there is no response, one can add topical voriconazole. But if the ulcer size is large and the depth is more, then you have to give topical natamycin with systemic antifungal agents, add topical voriconazole, and if after 4 weeks there is no response, add intracameral or intrastromal or both. We've also worked at water-soluble natamycin, which is going to be available with the microvision very soon, and it's a clear solution when you compare it with natamycin suspension with higher peak for a prolonged period of time as well. We have now evaluated it in the various clinical studies as well and intrastromally. So this is intrastromal natamycin, which is soluble in cells, and this is yet another case with this is a case with intrastromal. We evaluated all the 3 injections, the intrastromal, the natamycin, as well as amphotericin B, and we found that intrastromal natamycin was the best, and there was vascularization with amphotericin B. Other formulations in antifungals could be in the form of liposomes, drug-loaded polymeric missiles and nanoparticles, and of course the efficacy of this needs to be established. Now, coming to acanthamoeba keratitis, we continue to give biguanides like PHMB and propomidine in combination therapy, but thinking does have a role in cases of acanthamoeba keratitis. And oral miltefosine is again, which has been tried in refractory cases of acanthamoeba keratitis, and it responds to therapy. Now, we've also been taken aback by the newer organisms that we have discovered. For instance, in this case of fungal keratitis with hyphae, which showed corneal thinning and guttering as well. And the patient also had bacteria, so was started on topical antibiotics as well as topical antifungals. But the patient had endophthalmitis, panophthalmitis, exenteration, and finally, when the blast search was done with the NCBI data, these are the newer organisms which we discover based on the nucleotide sequencing, and this is its advantage. But we've also role of Tenon's patch graft. The advantage of this Tenon's patch graft is that it is not autologous. You don't have to prepare it from anywhere. You don't have to, like a case of, and there are no rejections because it's the patient's own tissue. So this can be sutured if it is a large perforation, or it can be glued onto the site of the perforation. And once this is done, then the anterior chamber forms quite well after you put the air bubble there, and also the results are very good. And this was especially useful in the COVID era when there was a paucity of any type of donor tissue, and so it helped to seal perforation. Packing or packed CXL again, keratitis, but the results are awaited. There are known large-term studies which have proven its efficacy, and we require larger number of patients with more studies. There is another alternative to riboflavin, and that is so RBP that has microbial therapy, and again we do not have to evaluate this further. As far as keratoplasty is concerned, therapy and cases of fungal keratitis. So the donor corneas are cross-linked and then they are sutured. Wonderful work which is done by Dr. Anjana Karunakaran from Kerala in RP Center, and this work was published in ophthalmology. There can be recurrence even after therapeutic PK, so multi-prong attack, more than one modality to treat these cases of microbial keratitis. Now time to rewind, reevaluate, find our approach, because there is drug resistance, because there are not many newer drugs which have been tried, and because we are dependent upon the bugs or upon the microbes, but also dependent on the fact that there is inflammation apart from infection, and that needs to. Of course, you require regular audit of ulcer cases and redefinition of protocols from time to time. So thank you very much.
So thank you so much. She was kind enough to record, even though she was not able to come in person. She recorded and sent the video for us. Thank you so much, Dr. Namrata. Dr.
Yes. I'm going to try now. I've changed my laptop. Not coming. System preferences. Unknown. Go here. Yeah.
Ma'am, probably what we can do is maybe you can share the video to the AV people. We can play it from here and you can talk from there if that is okay for you.
Yeah.
And meanwhile, we'll move on to the next
Meanwhile,
topic.
move on.
Yeah.
Yeah.
Okay. So the next topic is going to be Dr. Ramya. Vaishnavi, we are not able to hear you. Yeah. Can you unmute yourself?
Yeah. Dr. Ramyaman is next.
Yeah, that's right.
Okay.
You can go ahead.
So our next speaker will be Dr. Ramya Sampath. She is the regional head for clinical services and is a senior consultant in our Department of Refractive Surgery. She was recently inducted into the Asia Book of Records for performing the maximum number of refractive eye surgeries in a single day by an ophthalmologist. She has over 10,000 refractive surgeries to her name. I invite you to talk, ma'am. Please come.
Just 1 second. Host is not allowing me to share my screen. The host has to give me permission.
Allowed, madam, allowed.
Okay. Am I audible?
Yes, madam.
Is the screen seen?
Yes, it's visible.
So, the biomechanics of the cornea governs its shape and therefore its refractive power. Gaining comprehensive understanding of how the biomechanical properties of cornea contribute to its shape has become increasingly important ever since the introduction of refractive surgeries in 1990. There are 60 million refractive surgeries happening worldwide, and state-of-the-art procedure is, of course, SMILE. The future of the refractive procedure is SMILE, and as you all know, SMILE is a small incision lenticular extraction, which has been approved in US by 2016 FDA. It is a Carl Zeiss Visimax femtosecond laser system with an infrared laser working in a wavelength of 1043 nanometer and a frequency of 500 kilohertz. It works on the principle of photodisruption. What is photodisruption? The laser creates a close-knit pattern of femtosecond pulses at the designated position and depth. In photodisruption, the laser energy is absorbed by the tissue without any significant increase in heat, which results in plasma formation. The expansion of this plasma leads to the formation of gas or cavitation bubbles, leading to the formation of a cleavage plane, which can be broken mechanically. So indications are pretty much same for any other refractive procedure. Myopia from 0.05 diopter sphere up to 10 diopter sphere can be corrected with SMILE, and astigmatism up to 5 diopter cylinder can be corrected. Age more than 18 years. Mesopic pupil size of less than 6 to 7 millimeter. Residual bed thickness of more than or equal to 250 microns. We prefer keeping at 280 microns. It's a surgeon's call. Central corneal thickness of more than 480 microns. Stability of refraction of more than a year. Contact sports and professional requirements are some indications for SMILE. Contraindications. Absolute contraindications are keratoconus, pellucid marginal degeneration, or any ectatic disorder, pregnancy, cataract, uncontrolled uveitis and glaucoma, severe dry eyes, ocular allergy, deep corneal opacities, and infections. Relative contraindications being less than 18 years of age, diabetes mellitus, autoimmune disorder, dry eye, irregular corneal astigmatism, immunodeficiency status, one-night lactation, and EBMD, which is causing RCE, recurrent corneal erosions. The settings for SMILE are with a pulse energy between 140 to 200 nanojoules, spot distance of 4.5 microns for the lenticule and cap, 2 microns for the lenticular and cap side cut, track distance of 4.5 for the lenticule and cap, and again 2 microns for the lenticule and cap side cut. The energy offset is somewhere between 28 nanojoules to 40. Cap thickness again between 100 to 120 microns. Cap diameter is always 1 millimeter larger than the optical zone. The optical zone can be designed somewhere between 6 to 6.5 microns. Incision position can be planned at 90 degrees or at 120 degrees, and incision width can vary between 2 to 4 millimeter. The cap set angle can be between 45 degrees to 135 degrees. The transition zone is 0.1 millimeter for the cylinder and 0 for the sphere. Minimal lenticule thickness can be between 10 to 30 microns, and the total suction time ranging between 22 to 30 seconds. Docking and femtosecond laser delivery. The selection of the cone is dependent on the Y-to-Y diameter. So we have 3 different cones: small, medium, and large, and the SI cone ranges between 8.6 millimeter diameter. The bed, it is brought up to the cone, and which applanates up to 80% of the corneal surface while making sure of the centration. So here the bed moves up and down, and the suction device, the laser coupling device, the interface cone will be fixed. That is where we call as a docking. I'll show you in the subsequent video. The laser treatment is centered over the coaxially sighted corneal light reflex. Once the desired centration is achieved, the suction is started. The suction rise achieved is approximately around 80 to 120 millimeter of mercury. The intrastromal lenticule is fashioned in spiral in, that is the posterior surface of the lenticule. Lenticular side cut is followed by that, and then the cap or the anterior surface of the lenticule, which is fashioned in spiral out manner, and finally the incisional cut. This form of spiral in and spiral out is practiced so that the patient can have the fixation during the maximum period of the procedure. So this is how it is. In the left, you have a pictorial representation. 1 is the lenticule cut or the undersurface of the lenticule. 2 is the lenticular side cut. 3 is the cap cut or the anterior surface of the lenticule. And 4 is the incisional cut. Picture A shows the centration. Picture B shows the posterior surface of the lenticule, which forms out to in. Picture C shows the anterior surface of the lenticule, which goes in to out. And finally, the incisional cut. So the lenticle dissection and extraction. To help in a better lenticule dissection and extraction, we have different signs such as white ring, shimmer, meniscus, and stop sign. The white ring sign is being described by Jacob et al. In 2016, which is seen as a white ring posterior to the dissecting instrument during the anterior plane and anterior to the instrument during the posterior plane dissection. Shimmer sign is described by Shetty et al. In 2017, seen as a bright reflex around the dissecting instrument, not visible during the dissection of the anterior plane. Meniscus sign, which has been described by Titial et al. In 2018, seen as a meniscus-shaped gap between the inner cut and the lenticular edge. The stop sign, which has been described by Sachdev et al. In 2020, this is noted as a point of resistance at the junction between the dissected and undissected halves of both the anterior and the posterior planes. So the extraction of the lenticule is done in a segmental sequential dissection method. We prefer creating two pockets, one the posterior and the anterior. The dissection should be the anterior first. The anterior plane is dissected completely, followed by the central part of the posterior plane. The peripheral rim is dissected in 2 clock hours manner. A part of the peripheral rim which is towards the incision is always dissected last to have a better anchorage. The lenticule is then removed using a McPherson's or MST forceps. So once the docking is done based on the CSCLR, the suction is activated and the laser pass, that is the posterior surface of the lenticule which goes out to in. Then we have the anterior surface of the lenticule which goes in to out. Finally, the incision cut 2 mm at 120 degrees. So we open out the incision, we create the posterior pocket and the anterior pocket, and the dissection should always be anterior first. When we dissect the anterior, we have to go up to the peripheral rim, the anterior outer surface of the rim, and the lenticule has to be dissected completely. Then we dissect the posterior. We go centrally. If you see, the lenticule is above the instrument, which confirms that we are in the right plane. We will be having some resistance, which again confirms we are in the right plane. We go up to the 6 o'clock, dissect, and in the segmental sequential manner, we dissect the rim and leaving the 2 o'clock near the incision, and finally the lenticule is removed. For beginners, I would advise you to place the lenticule over the cornea and examine whether you have removed in toto. The various modes available in the SMILE machine are the expert mode, standard mode, and the fast mode. The pulse energy varies between these modes, whereas in expert mode, we have the 140 to 200 nanojoules, standard 130 nanojoules, and fast mode is 170 nanojoules. Energy offset is 28 to 40 in expert mode, and standard mode it is 26, fast mode it is 34. Track distance and spot distance are pretty much same for the expert mode and fast mode, with a lenticule and cap of 4.5 microns and lenticule and cap of 4.5 and 2 for the side cuts. In case of standard mode, the track distance is lenticule and cap has 3 microns, and spot distance lenticule and cap side cuts has 2 microns. Complications. The intraoperative complications are suction loss, vertical gas breakthrough, opaque bubble layer, black spots or non-lasered areas, subconjunctival hemorrhage, cap lenticular adhesion, retained lenticules, cap tears, lenticule tears, epithelial defects, and decentered ablations. So incidence of suction loss during SMILE ranges between 0.9 to 4.4%, but in the recent times with use of current software and experience in SMILE procedure, it has decreased from 0.17 to 0.93%. So most of the suction losses frequently are experienced during the anterior lenticular surface pass. Opaque bubble layers. Generally, entrapment of these entrapment of the cavitation bubbles under suction pressure causes these opaque bubble layers. The incidence for the OBL to form are 0.73%. Generally, the risk factor for OBL would be a thick cornea, thin lenticule, stiffer corneas, high laser energy settings, increased line spacing of the laser spots. Increased force during docking and repeated docking can also increase the incidence of opaque bubble layer. Black spots or non-lasered areas are occurrence of multiple small black islands of incomplete photo disruption, and the incidence varies between 0.3% to 11%. Generally, black spots occur due to the entrapment of debris such as water droplets or air or meibomian or conjunctival mucus secretion at the interface between the laser coupling device and the corneal surface, which blocks the laser. So hence, this makes the dissection of the lenticule difficult due to the micro adhesions. However, this does not hamper with the visual outcomes. Subconjunctival hemorrhage is one of the rarest complications. This occurs when the high suction pressure is applied over the cornea. Then we have some incisional bleeding. So the incisional bleeding can happen due to eccentric docking of the suction cup or in case of pannus. Incisional tears ranges between 2.1% to 11% of incidence. This happens during the early learning curve, and this is due to the increased manipulation during dissection, smaller incision site, or a strong Bell's phenomenon. Epithelial defects can happen and the incidence ranges between 0.17 to 11%. Again, it's in the beginners or novice surgeon. So other intraoperative complications during the lenticular dissection or lenticular extraction would be unintended posterior plane dissection and cap lenticular dissection. So what happens is this may create false plane or a typical lenticular adhesion, which ranges between 0.3 to 7%. So suction loss, there is a treatment or management protocol given by the manufacturer at different stages of suction loss. The procedure can still be continued. If we experience suction loss in the initial phase, that is less than 10% of the lenticular cut, it can always be redocked and we can restart the procedure. If we experience suction loss more than 10% of the lenticular cut, this has to be converted to a femtoLASIK in the same setting or can be converted to a LASIK in a different setting. Lenticular side cut suction loss, we can always repeat, we can redock it in the same setting by decreasing the lenticular diameter of 0.2 to 0.4 millimeter. Cap cut, we can proceed in the same setting. And cap side cut, again, we can redock, decreasing the setting of the diameter of 0.2 to 0.4 millimeter. Another 5 kilometers. Like which is similar to any refractive surgery with dry eye, keratitis, infectious keratitis, corneal ectasia, postoperative complications specific to the femtosecond laser would be the transient light sensitivity syndrome, pressure-induced stromal keratitis, interface fluid shift syndrome, interface Bowman's membrane distortion. In case of transient light sensitivity syndrome, it is very specific to femtosecond lasers, where due to the irritation of the bubbles or the femtosecond laser, it might cause a reaction which typically occurs in 2 to 8 weeks. It has a robust response to steroids. Although the etiology is not well known, it has a good visual recovery. Pressure-induced stromal keratopathy or pressure-induced stromal keratitis is very typical to SMILE procedure, where we will be able to see due to elevated intraocular pressure, visible fluid clefts in the interface. Again, the patient presents with worsening of vision, pain along with increased intraocular pressure. Treatment would be to start with anti-glaucoma medications and patient will recover well. Interplace fluid shift syndrome or shifting ectasia is a very, very rare thing which is reported after SMILE, where due to increase in the fluid change in the particular region causes steepening, and this can be treated with topical hypertonic saline. Interface debris during lenticular extraction or during lenticular dissection can happen from debris from the glove, fiber from the sponges, or dry ocular surface, metallic particles, instrument, meibomian gland secretions are from this. Most of the time, interface debris are biodegradable. Unless and otherwise it causes reactions, nothing much to be treated with this. Bowman's membrane microdistortion typically affects the, typically happens when we have a power more than 6 dioptrosphere. It doesn't have an impact on the long-term visual outcome. Vision-related complications like any other refractive surgeries, we have refractive surprises, overcorrection or undercorrection. Increase in higher order aberrations such as induced coma when we have a more decentered lenticule, or increased spherical aberration can cause spherical coma, increased spherical aberrations, which leads to poor visual quantity like glare, halos, and it affects the contrast sensitivity also. What are the advantages of smile over PRK and LASIK? Generally, smile is called as a flapless, bladeless procedure. It is called as a keyhole surgery, which has only 2 to 4 millimeter of incision. It is biomechanically stable. Corneal sensations or re-innervations are better preserved, hence the dry eye symptoms are less. Inflammatory reaction is less. It has better contrast sensitivity. The visual recovery is slower, but the wound healing is faster because it's a minimally invasive procedure. It is a single laser pass and it corrects high myopia, steep corneas too. The limitations, at present, it is not FDA approved for hyperopic and presbyopic corrections. So just a word about Wisdomax 800 or Smile Pro. The dissection, the lenticular dissection time is only around 8 seconds. It has a pulse repetition rate of 2 megahertz compared to the special, the current Smile machine, which works at 500. It has better ocular pattern rotation for cyclotorsional alignment too. Thank you.
Thank you, Ramya, for giving loads of information regarding smile with your smiling face. Thank you so much. And can we have Dr. Athya Agarwal now to talk to us on advanced phaco and glutathione? Ma'am, are you able to share now?
I've asked Ravi to play my video, just see if he can do it.
Sure, ma'am. Ravi?
Sure, madam. Sure, madam.
Yeah, please play the video. Yeah.
Where am I seeing myself?
Ravi, can you play it?
Ravi, can you play the video, or otherwise we'll go to the next speaker?
No, no, yes, madam. Yes, madam. The play. It's done, huh?
Off the audio. Mute.
Audio
mute.
mute. Audio mute, madam.
Extraocular movements,
No.
uniocular movements,
Wait, madam.
supraduction.
What are you playing? Play my second video first, not the first.
Second video. Second video.
Okay. Sandri, if you feel like we are wasting time, move to the next
No,
person.
ma'am. We'll wait for a minute because you've already sent the video. I think.
Okay,
they
if
should
you
be in
can't play the
position to-
second, play the first.
Ravi, are you having it or no?
Should I try again? What's the problem? Ravi?
Ravi, are you able to share the video?
What's the problem?
Video is playing, madam. Wait, madam.
Where it's playing? It's
Please-
not
please
coming on
share
the
it.
screen. Okay, Soundri, move on, Soundri. Move to the next speaker.
No, ma'am. We'll wait for a minute. Just a minute. I'll just check. I'll go and check it out.
Yes,
Yeah, play this one first. Yeah.
No, correct. So,
Stop for a while. Soundri, can you hear me? Soundri? Can you hear me?
Ma'am, you heard quite well, ma'am. We can
Okay.
hear you.
Stop the video for a while. Stop it. Yeah. Can you stop the video?
Ravi, if you
No.
can hear,
Can
ma'am,
you, if you
stop.
can hear me, stop the video.
Ma'am, I'll just call him.
Okay. Anyway, I'm sorry for all the troubles. My new laptop Mac Pro, which I bought, did not let me play it, so I'm playing through Ravi. So welcome to this Kalpavriksha and Kala has spoken so much on the
Yeah.
basics of the phacoemulsification. I was asked by Sondri to do something on advanced phacoemulsification. So I had to take some videos which are a little bit advanced for you people, but I'm trying to make it as simple as possible. So I've selected this video of Sommering ring. Just play the video now. Now, what is a Sommering ring? Ravi, please, whenever I say stop here, stop here, stop here. Okay, what do you see here? Stop the video, Ravi. Can you stop the video? Ravi, stop the video for a while. No, okay. So Sommering ring is nothing but, if you see here, you can see a ring which has gone behind the iris, and the center of the nucleus is very clear. You're only seeing a ring in the periphery. This is called a Sommering ring, which is nothing but it's a type of after cataract, which are described by Sommering in 1828. And what happens sometimes in young adults, either there is a trauma or some kind of operation like a decision or needling, or for any trauma, just you have operated the patient, or you have done an extracapsular cataract extraction in which you have removed the central nucleus and you've left so much of the cortex and both the capsule behind, usually due to penetrating trauma or of a needling operation or decision or even Fukala operation for myopia. In all this, the surgeon has removed the central part of the nucleus. So the center is clear here and there is a ring surrounding it, which is nothing but it's a type of after cataract. The remnants of the cortical matter gets entrapped between the anterior and the posterior capsule, and they form a ring which actually goes behind the iris and remains there, but the center is clear. So obviously the patient has got aphakia. So these patients come to us to manage the aphakia part. Now, before we manage the aphakia part, we have to also consider this ring, because this ring has to come out. So you must have heard so much about the glued IOL, in which if you don't have a capsule, instead of putting an anterior chamber lens, we do something called a glued IOL surgery, in which we, without the capsule, we take a 3-piece IOL and we implant it inside the eye, but the optic is inside the eye, but the haptics are externalized and they're brought on the scleral bed after creating 2 scleral flaps. As you are seeing on the right hand side, I have dissected a flap 180 degrees apart and I made a scleral flap just like any trabeculectomy flap, and I'm dissecting it. Play the video now. And I have dissected the flap on at 3 o'clock. Play the video, Ravi. So I'm dissecting it up to the limbus. This is a partial thickness scleral flap. This is how a glued IOL is done, in which we take a 3-piece IOL and we implant it. But any of these glued IOL surgeries have to have fluid going inside the eye. So I have placed a cannula just behind the limbus. Under the scleral flap, we create a sclerotomy with a 22 gauge needle so that we can enter the eye and externalize the haptic. A 2.8 millimeter incision is being made there, and a 3-piece IOL is taken and a glued IOL forceps goes inside. Either I have to do it myself or my assistant is going to rotate the injector so that the haptic comes out first. Holding the tip of the haptic, we bring the haptic out on the scleral bed and the assistant is holding it. And same thing you have to do on the other side by using a technique called handshake technique, in which we hold the middle of the haptic, but be careful here that you do not damage it. Once again, going with the glued IOL forceps through the 22 gauge sclerotomy, you externalize the haptic and bring it out, and using a 26 gauge needle, you create scleral tunnels or scleral pockets, and in the scleral pockets, you have to tuck these haptics. For all this, you have to use only a 3-piece IOL. By 3-piece IOL, what I mean is when the haptics have to be more flexible, they are a different blue type of haptics. Now, once you put this intraocular lens inside the eye, which is going to act as a scaffold. In this particular patient, I'm not able to stop it myself. Otherwise, I would have stopped and explained to you. So whatever I can do in this thing, okay. So now what we have to do is, I implanted the lens before I could remove this sommering ring. So this sommering ring is still there. We are not going to let this ring fall back, because no literature shows that any of the sommerings, which are nothing but the cortical remnants of an encapsulated between the anterior and posterior capsule, they cannot be dropped back into the vitreous cavity. So we have placed the lens, which is going to act as a scaffold. By scaffold, what I mean is, I'm creating my own posterior capsule, or I'm creating my own platform on which we are going to free these sommering ring, and then I'm going to remove it with the phaco handpiece, because these are very thickened rings. They cannot be taken out with a vitrectomy. Now what is happening? I've taken a vitrector. I'm going through the eye after implanting the lens, and I'm going to do a little bit of vitrectomy so that I can release the adhesions. Once these adhesions are released, these sommering ring, part of it, of one half, have been now loosened out and they've come anteriorly. But if you see here, the scaffold, the optic of the lens, which are put as a scaffold, is going to stop them from going back. So I've taken the phacoemulsification probe and I've taken them all out on one side. Once we finish doing that, I moved the iris hooks to dilate the pupil, because the pupil is not dilated here, and did the same thing on the other side. And using the phacoemulsification probe, fluid is flowing inside the eye always, because any of these gluteal surgeries you cannot do without fluid inside the eye. Once again, the vitrector goes inside, releasing the adhesions. This ring may not fall back. So I have taken a forceps in my left hand. I've gone and I'm holding on to the ring so that it doesn't go back to the gap between the lens optic and the iris, and then emulsified it. So what did I do? I did an IOL scaffold for this sommering ring, which is nothing but cortical remnants of the cataractus lens, which was removed long back in a young adult. After doing that, the scleral flaps have to be sutured with a combination of fibrinogen and thrombin, which I call it as a fibrin glue. The scleral flaps are now glued. The conjunctiva is glued using the same glue. Air is injected. The cannula which went inside with the fluid is removed. The same glue is now used for closing all the paracentesis which I created there. This is how the patient is going to look post-operatively. These are all young adults who are sent to us because they've been aphakic for a long time. They did not have a lens inside, and we didn't have a choice other than doing a glue dial in this case. I hope I was clear in telling you what I did. Play my next video then. Since I've taken the advanced cases of phacoemulsification, I want to show you another case in which the surgeon has operated a case and they have left the lens, which is the intraocular lens, which is now subluxated. This is a subluxated one-piece non-foldable lens. Patient has left it there, and we are planning to do a glue dial in which we have to measure the wide-to-wide diameter. If the wide-to-wide diameter is less horizontally, you can do a vertical glue dial. Now, what do we have to do? This is a one-piece non-foldable intraocular lens put by the surgeon. But for glue dial, you have to use only a three-piece foldable intraocular lenses. But in this particular case, since this lens is already there, I'm going to do a glue dial with the same one-piece non-foldable lens. And the iris is also very badly damaged here. You can see me doing the same thing. The scleral flaps are created 180 degrees apart. But in this particular case, the flaps are created at 12 o'clock and 6 o'clock instead of 3 o'clock and 9 o'clock, because the horizontal diameter is more than the vertical diameter. So you can do this way also a glue dial in which you have to make the scleral flaps at 12 o'clock and 6 o'clock. You can see the iris is so badly damaged and the haptic is gone and stuck into the iris. Using the handshake technique through the sclerotomy, I'm using two glue dial forceps, going and releasing this haptic and holding on to the tip of the haptic. You have to be careful here because this is a one-piece IOL. Normally for a glued IOL, you have to have the haptics which are different than the optic. But in this particular case, I don't want to enlarge the incision and remove this intraocular lens and put another 3-piece. So you have to be careful. A vitrectomy has to be done because we don't want all this material, any vitreous coming there or any capsular remnants, because we don't need the capsular remnants here, because here the optic is going to be inside, but the haptics are going to come outside and we'll be tucking them into the scleral pockets, which I'll be showing you soon. So a thorough vitrectomy has to be done. If the need lens material is gone back, you can remove that also through a 3-port vitrectomy. You can go on using the handshake technique, in which you can shake your hands in such a way that you take the haptic, going on passing from one hand to another, till you go on holding on to the tip of the haptic. Be careful, because these haptics should not break. Otherwise, you have to do another incision and remove this IOL and implant another IOL. Scleral pockets are created. We call it Gabor-Chariot's tunnel with a 26-gauge needle into the, or they are called intrascleral pockets, in which we have to tuck this haptics into the intrascleral pockets. This is called a haptic tuck. My assistant is holding on to the scleral flap. This is a partial thickness scleral bed which I created. A sclerotomy is done with a 22-gauge needle. Now, once you finish this, you cannot leave this pupil so much dilated, because the surgeon has created a lot of confusion in the iris, which is now fully dilated. Patient is going to have a glare. You cannot leave this as such. So you have to do a single pass 4th row pupilloplasty, which is nothing but you take a Prolene needle, you go to the clear cornea on one side, bring it to the iris, pass it through the iris on one side, then railroad it through a 26-gauge needle, create a loop, bring the loop outside, cut the other end. This is called a single pass, because you can see the Prolene needle has gone through the iris only once. So that's why it is called a single pass. But when you create a loop, you pass the loop into onto itself 4 times. So it is called a single pass 4th row, because we threw the Prolene suture 4 times into the loop, and when you oppose the 2 ends, this is going to create a very nice hug there onto the iris, and the iris is closed. You can see the pupil is getting shorter and shorter, because we don't want to leave the pupil so much enlarged and leave the patient with glare. Single pass 4th row pupilloplasty is such an easy procedure. Anybody can learn it, because it is a very, very easy technique. You can go on suturing the iris whenever you, how many ever times you want. At the end of it, you have to check by all this manipulation, any vitreous came out. So triamcinolone went inside the eye and cleared it off. These scleral beds have to be now this thing nicely with the fibrinogen combination, which we call it a fibrin glue. And this is how the patient looked on the left-hand side preoperatively. And that's how the patient looked post-operatively, with a nice and small pupil. So these are the few cases I selected because of lack of time. Otherwise, I would have shown you more cases. Thank you very much. And sorry for the confusion I created so much with my videos. Thank you, Soundri.
Absolutely no worries, ma'am. It was an excellent session. We all thoroughly enjoyed it. Thank you.
Thank you.
So our next speaker is Dr. Susan. Dr. Susan Jacob. She really needs no introduction. She's the director and chief of our cornea department with over 20 years of experience. She has countless accolades to her name and multiple innovations in the field of ophthalmology, one of which she will elaborate on now. She was recently selected to the Power List 2021, which is an annual list of the top 100 women ophthalmologists in the world. Over to you, Susan, ma'am.
I will just share my screen. Just give me a second, please. Okay. So which screen are you able to see? Do you see? Hello? Do you see the one?
Seeing you?
Do you see my screen? Not yet.
Not
No,
yet.
has
I
started.
can't see it yet, ma'am.
No, Susan has started sharing. Screen is showing.
I did start sharing, but you're not seeing me as yet.
No,
No.
not
I
yet.
mean, you're not seeing the screen as yet. Okay,
No,
just
no, no.
I'll just do it again. Mm. To get it 1 second, please. Can you see it now?
Yeah. Yes.
Which one? LASIK case selections and methods? Is that
Classic case selection and methods.
okay, fine. Thanks.
Yeah.
So I'm going to be talking on 3 things. One is a little bit about refractive surgery, which Ramya already covered up one of the techniques very nicely. I'll just be giving a little general overview about it. Then the second thing is about ectasias, and the third topic is going to be about a little bit about a new technique which is called CARES. So yeah. So you know what, when you're looking at refractive surgery, when you look at it, some of the things that you do when you see a patient is this patient suitable for surgery or not? So when you look at patient considerations, can just someone just let me know if it's about 7 minutes into the talk, please. Yeah, thanks. Vaishnavi, if you can just let me know that. Or Sujata, if you can let me know that, just 7 minutes into the talk. So patient considerations, when do you do LASIK or when do you do refractive surgery? Generally, we know that the patient has to be an adult, which means at least 18 years, preferably 21 years and above. But there are certain situations where you also do it in pediatric age groups. One of them is when the patient is less than 7 years old. In that case, if the patient is less than 7 years old, you could do it in a case of anisometropic amblyopia, where the patient is intolerant to contact lens. And more than 7 years and between 18, that is 7 to 18 years, also sometimes if there's a significant anisometropia, a patient who's intolerant to contact lens and glasses, you would still want to do it. And all of these are, of course, to basically avoid amblyopia. So there are many cases where there is a lot of anisometropic amblyopia. The patient is unable to wear contact lenses. Glasses are not the solution because of the anisometropia. And just to prevent amblyopia, you may do it in younger patients also. Some of the other conditions where you have to be a little careful for corneal-based refractive surgeries are herpes simplex virus, obviously herpes zoster virus, significant dry eye, allergies, blepharitis. You have some corneal diseases, scars, neovascularization, corneal abrasions, recurrent corneal erosion. Of course, these may not be absolute contraindications. Some of them may be, but it just says that when you see a patient like this, you have to take a little extra care. Ptosis, lack of thalamus, exposure, squint. So you might need to treat some of the other conditions first. For example, dry eye, you might have to treat the allergy, you might have to change your plan if you have a corneal scar or a recurrent erosion syndrome. Things like that come into play. And of course, if you have some other coexisting morbidities like cataract, uveitis, glaucoma and all, you do give consideration to that as well and decide about which is the best way to manage this patient. If the patient has cataract, obviously cataract surgery would be the answer. And if you have glaucoma, there are other implications of doing refractive surgery. So think about all these things. Specific ocular considerations when you're considering refractive surgeries. One is if the refraction is unstable. Obviously, if the refraction is unstable, you're not going to be doing the refractive surgery immediately. You wait for stability, and 3 stable refractions 1 month apart is one of the things. And sorry, that's for retreatment. I'm sorry. 3 stable refractions which are done with a reasonable period in between is what is considered as a stable refraction. It could be even 6 months apart, 1 year apart, till you see that the refraction is completely stable and the topographies are also stable. You do not do refractive surgery. If the cornea is too thin, again, you don't do refractive surgery, because the corneal-based refractive surgery, because you're going to be removing some of the tissue in corneal-based refractive surgery. In those cases, you could do lens-based refractive surgery. Large pupils, high correction and astigmatism, for example, more than 12 diopters, you may not even think of, even in fact 10 diopters, you may not even think of refractive corneal based refractive surgery. High astigmatism, more than 6 diopters, or hyperopia more than 6 diopters, again your success rate starts to come down, and so you can think of other reasons or other ways to manage this condition. Previous refractive surgery, curvature abnormalities, keratoconus FFK is of course a contraindication, keloid formers also contraindication. So these things are things that you have to consider. Systemic conditions, for example, diabetes mellitus, connective tissue disorders, immunodeficiency disorders, pregnancy, lactation, and certain systemic medications, for example, isotretinoin, which is used commonly for the treatment of acne. Remember that it does have a lot of effect on the eye, and it could cause a lot of scarring post corneal based refractive surgery. So you have to stop that medication before you even consider the patient for refractive surgery for some time. Amiodarone, sumatriptan, which is used for migraine, all these things can cause corneal issues, and so you have to really stop these medications before you go in for surgery. Patient types, if the patient is unrealistic, you really have to sit down and take some chair time and explain to the patient what you're going to be getting out of the surgery. Very fussy patients who are not willing to accept any kind of residual glasses, you have to explain to them that this is not a magic surgery. Of course, you always have a wow effect with the corneal-based refractive surgery, but you have to explain them that there is a possibility in a small percentage of patients that they may have residual glasses. So explain all the possible complications that can happen post-refractive surgery. For example, residual refractive error is one of them. Psychological diseases, not willing for any risks. These are other obviously patients whom you have to take extra time talking to them about. Contact sports such as boxing, wrestling, martial arts, etc. You may not do a LASIK. Instead, you may do a PRK or a SMILE, as Ramya was just talking about. Defense, police, also similar things. And working conditions are other things that you have to think about. Specifically, when you come to the patient, look at if the patient has got a deep set eye or if the patient is uncooperative. If it's a child, unstable fixation, a large angle kappa, nystagmus, these are all things where you might have to change your approach a bit to the refractive surgery. Now, when you come to the refractive surgery per se, you have different types, different techniques. One is surface ablation, generally which is called as advanced surface ablation techniques, epiLASIK, LASIK, PRK, transepithelial PRK. All these are newer kinds of advanced surface ablations. You have sub-Bowman's keratomelusis, which means that the LASIK flap, it's similar to, it's exactly same as LASIK, except that the LASIK flap has been made extremely thin, that is between 80 to 100 microns. LASIK is the age-old procedure where which combines both the very thin, ultra-thin flap LASIKs as well as the LASIK flap, which used to be done, at least a decade ago, where the flap thickness would even be up to 200, 160 microns. So that whole entire thing encompasses LASIK. But currently, the LASIK that is performed includes only the thin flap LASIK because no one creates these thick flaps anymore. Flex and smile are other techniques which Ramya already explained. And everything from here to smile is all cornea-based refractive surgery. Phakic IOL and clear lens extraction are the lens-based refractive surgeries. So coming to cornea-based refractive technique, because that's what we are going to discuss about. As I already said, you have surface ablation, which includes PRK, LASIK, and epiLASIK. You have LASIK, which can be again of two types, microkeratome and femtosecond laser, using which basically denotes the type of the way that the flap is created. You have all femtosecond laser, which is basically flex and smile. And here everything is done using only a femtosecond laser. Whereas in LASIK, once you make the flap, excimer laser is used to treat the refractive error. And of course, in surface ablation also, the excimer laser is used to treat the refractive error. So a lot of things, again, LASIK flap healing, there is something called LASIK flap healing. So if you don't want that LASIK flap healing to happen at all, in the sense that you don't want flap displacements or flap related complications, then smile is a very nice technique which decreases the risk to a large extent. Corneal biomechanical effects, for example, PRK and smile have a lesser effect on the corneal biomechanics than LASIK, because the LASIK flap we know contributes nothing to the biomechanics of the cornea. IOP measurements are important, especially you know that you've thinned out the cornea, so you do have to apply correction factor later on. IOL power calculation is important because LASIK does have an effect on IOL power calculation. So it's ideal to do an IOL power calculation even before you do the surgery on the patient and store this data for future use. Dry eyes, because of corneal nerve transection, it does create a temporary dry eye post-surgery, and therefore patient who's already got underlying dry eye has to be treated prior to surgery. Remember that LASIK does have certain other effects, such as an increased risk of eye infections, or a different kind of eye infections rather. If you get a keratitis post LASIK surgery, it's really different because it's in the interface, and the way you treat it is also different. Post LASIK visual quality you can sometimes get aberrations, but the newer software really, yeah, done.
Sorry to interrupt. Yes, ma'am.
Okay, thanks. Newer techniques are really very, very effective for this. Now, PRK, you can remove the epithelium. PRK is basically epithelial removal followed by excimer laser ablation. The epithelium can be removed using just alcohol or plain mechanical debridement, or even using the excimer laser itself to first blast through the epithelium and then do the excimer laser ablation for the refractive surgery. The problem with PRK is, of course, the pain that's associated with it, the haze, the regression, and the need for long-term steroids, and also the lack of the wow effect, and also the discomfort for the patient that is associated with PRK. This is basically what PRK is. You put alcohol, or you can use the trans PRK, which is basically going through the epithelium with the excimer laser itself, removing the epithelium, and then going ahead and doing the excimer laser directly on the stromal surface. Of course, you have to use mitomycin C when you do PRK to prevent or decrease the risk of haze. EpiLASIK is where you use an epikeratome, which is a blade, but the blade is completely made of plastic, so it's a blunt blade, and it basically scrapes off the epithelium And then you go and do the same similar procedure, such as it scrapes off the epithelium as a flap. So the flap is kept aside, the epithelial flap is kept aside, and then you do the PRK, and the epithelial flap is replaced after the excimer laser ablation. LASIK differs from this in removing the epithelial flap as a flap by using alcohol. So both of these rely on the presence of an epithelial flap followed by excimer laser ablation to the stroma. And the advantage is that they say that it really helps in wound modulation and decreases the pain and the haze that is associated post direct PRK. But the number of people who used to do epiLASIK and LASIK used to be considerable in between, but now the popularity of this technique has come down because of better because of techniques which are better. You can have some slow or delayed epithelialization even with epiLASIK. You can have corneal haze, epithelial erosion, etc. And the other thing is, even epiLASIK and LASIK, people used to do both epi on and epi off, which means after creating the flap, you would sometimes replace the flap, the epithelial flap over the over the ablated cornea, just as a sort of a biological bandage contact lens. But then there was also an epi off where you would just discard the epithelial flap completely. So as I said, it's not as popular anymore. But some of the indications for these advanced surface ablations are basically when you have inadequate corneal thickness for LASIK, or you have dry eyes, or you have those who are exposed to trauma, as I said, contact sports, signs of potential ectasia. You might combine it with an extra procedure, which means combining cross-linking with PRK, and so on and so forth. Okay, we already talked about this, subbowman keratomelusis. Then you come to LASIK. So LASIK is basically where you create a flap. This could be using a microkeratome as seen here. And then you have this blade which goes and cuts a flap. As you can see, it rotates. There's a forward and a reverse foot pedal. You press them forward and then reverse, and the microkeratome also moves forwards and reverse correspondingly. And that has a blade which lifts up a flap. This flap has got stroma also, unlike epiLASIK and LASIK, which has only epithelium. So you've got an epithelial and stromal flap, and the flap generally is confined to between up to 110 microns thickness. This flap, after excimer laser ablation is done, is replaced. And obviously it's a flap, so there is a danger of displacement, striae forming and things like that can happen. Thinner flaps have advantages, but then they also have sometimes disadvantages, and that's basically a microkeratome assisted LASIK. This is a femtosecond laser assisted LASIK, where you create a similar flap, but you use it using the femtosecond laser. And you can see that here there was a lamella cut followed by a side cut, and a hinge is left which is not cut, and then you open up this flap, and then once that's done, you do the excimer laser ablation and replace the flap back. What's the difference between this and microkeratome? It's much more precise. You can get the exact depth you want. It's safer because you can have vertical cuts, and so the risk of flap displacement is lesser, but still it does have some of the complications associated with flaps, which is it can still move. You can get striae, you can get epithelial ingrowths, and so on and so forth. So advantages of LASIK is a wow effect. You have very good correction of vision immediately. There's very little pain. Patient is extremely comfortable. But as I said, flap complications, dry eyes, biomechanical effects, these are still problems that do persist with LASIK also. So femtosecond LASIK, I already said it's got advantages. You can make thinner flaps, better precision, and so on. It's also got greater safety. But then you have the SMILE procedures, which completely get rid of a flap. You do it based on a cap. And the cap flex is again a flap based procedure where basically it's purely femtosecond laser. You have a flap that is lifted up, and then, as Dr. Ramya had shown, you have a lenticule that's also cut with a SMILE machine or with a femtosecond laser machine. This lenticule is extracted and the flap is replaced back. So there's no excimer laser ablation at all that happens in flex and small incision lenticle extraction. Small incision lenticle extraction or SMILE is a procedure where the flap is completely done away with. It's a cap, so it's basically a keyhole surgery. You just go ahead and extract this lenticule, as Ramya already showed beautifully, and that takes care of basically this part of this of the refractive correction. So I'll just stop sharing this screen and I'll go on to my next talk, which is basically okay. Sorry, about corneal ectasias. Okay, so now I hope you can see my corneal ectasia screen. Is it seen? Corneal ectasias, I think you can.
Yes, madam. Yes, madam.
So what's the definition of a corneal ectasia? It's basically a non-inflammatory condition. That's number one, hallmark of which is progressive corneal steepening and thinning, and is associated with a decrease in the uncorrected and best corrected visual acuity, along with an increase in ocular aberration. So that's what it does. It can decrease. Now, you need not always have a decrease in BCVA. It's possible that you have just a decrease in uncorrected vision, or you may not even have a decrease in UCVA and BCVA, but you might have just an increase in ocular aberration. So it will all depend on the stage at which you're seeing. Advanced stages, the UCVA will also get affected. Even more advanced stages, the BCVA also gets affected. But even in milder cases, you will have a change in alteration in ocular aberrations. So also it's a progressive condition. There's both the conical protrusion of the cornea or ectasia as well as thinning. It's because it can be because of genetic predisposition to this disease. We know that it could also be because of the chromosomal and enzyme abnormalities that are associated with it, and because of mechanical factors, which has been recognized to a great extent now. That is, eye rubbing or continuous microtrauma to the eye or to the cornea can cause this disease to occur and can even progress very rapidly. So keratoconus, keratoglobus, pellucid marginal degeneration, and post-kertorefractive ectasia are the types of corneal ectasias. So we know that in case of keratoconus, there's a lot of etiopathogenesis, as we already explained. Genetics, a lot of conditions which can be associated with keratoconus, such as Marfan's, Downs, so on and so forth. Also, there are biochemical factors which can also contribute to keratoconus, such as an increased level of proteolytic enzymes and a decreased level of protease inhibitors, increased pro-inflammatory markers, decreased anti-inflammatory markers, and so on. And as I already said, eye rubbing is one major factor which can be a biomechanical contributory factor to keratoconus or to other corneal ectasias. So what do you get? You get bilateral asymmetric corneal thinning, degeneration, and cone-shaped protrusion. And we already talked about some of the signs that can be, some of the symptoms that can be seen, which is basically a worsened visual acuity. You also see a lot of signs. You can see the Fleischer's ring. I'm sure all of you already know about this, which is iron deposit on the cornea and especially around the cone. You can also get the Munson sign, which is a V-shaped lower lid. When the patient looks downwards, the lower lid gets also pushed down following the bulge of the cornea. That's seen in very advanced cases. You may not see it in all cases. So this depends on what stage of the patient you're seeing in. If you shine the light on the temporal limbus, you can see that bright reflection on the nasal limbus. That's the Rizzuti sign. You can have corneal opacities because of spontaneous breaks in Bowman's membrane and corneal scarring, which can lead to visual loss. You can have compression of the Descemet's membrane, which are seen as fine vertical lines, which is what is known as Vogt striae. And you can have the hydrops, the acute hydrops, which happens in keratoconus because of the breaks in Descemet's membrane. So a lot of signs which can be seen. This is an example of the Munson sign, the Rizzuti sign, where you see this light being projected and concentrated onto that side. You can see thinning, you can see apical scarring, and you can also see Vogt striae as seen here, the vertical lines in the Descemet's membrane. And this is not the Fleischer's ring, of course. This is an early Munson sign. Fleischer's ring is seen as a hemosiderin deposit around the cone. So the oil droplet sign and the scissoring reflex, which are seen on retinoscopy. The investigations that you do to detect keratoconus are basically keratometry, where you see that the Mayas are irregular and they don't really superimpose well on each other. You can have photokeratoscopy, again, where instead of having circular placido reflex, you get an elongation or a compression of these rings, which implies to you that there is either a flattening or a steepening correspondingly, and an irregular cornea. Pentacam or Opscan or other kind of corneal topography machines can be used to diagnose keratoconus. Here's a classical example where you can see that the keratometric, the K1, K2, K2 is about 50.2 here, the steep K. K mean is 48.4. You have a higher level of astigmatism, 3.5 diopters. You have corneal thinning, which is about 409 in the thinnest location. So a lot of things which can happen. You might have a shifting of the thinnest part below minus 0.5. In this case, it's only 0.39. So these are all red flags. It need not be that every single sign has to be seen in every single patient. For example, here the thinnest location is not shifted more than 0.5, but those are things that can happen. Your AC depth could be higher in a keratoconic patient because the cornea is protruding forwards. So all these changes you can look at, and also look at this topography. The K max here is 57.1. The entire topography has got this asymmetric shape. Everything is shifted to one side. Generally, the infratemporal location, of course, being the commonest area of ectasia, and that this obviously leads to a decreased visual acuity. The other thing is the coincidence of all these abnormalities the anterior elevation is higher, the posterior elevation is higher, the thinnest is, the cornea is thinned down and it's ectatic. And if you look, it's all in the same zone or the same area of the topography, which again is a major pointer towards keratoconus. Lots of criteria which have been used to diagnose keratoconus, such as, the Rabinowitz criteria. There's a classification: mild, moderate, severe. Severe is more than 54 diopters based on the shape of the cone. It could be a nipple, oval, or globus cone. And you have the Amsler-Crumey classification, and so on and so forth. You have the ABCD classification, but based on all these classifications, you can classify the patient and decide on the treatment. And we know that the basic hallmark treatment is cross-linking, where for progressive keratoconus, where you are going to cross-link the cornea by using riboflavin solution and UVA light. And this helps to increase the strength or the biomechanical strength of the cornea by about 3 to 4 times from its baseline strength. And this prevents progression. At the same time, you also always have to tell every patient not to rub the eye, because that's again going to, even whatever kind of treatment you do, if you continue giving this biomechanical stress or trauma to the cornea, the disease will continue to progress. Cross-linking, as I said, is the definitive treatment for it, but in many patients you have thin corneas, and there are limitations or indications and contraindications for cross-linking. You have to have at least 400 microns of minimal corneal thickness, and many patients don't have this 400 microns of minimum stromal thickness. And for those patients, however, you have these advanced techniques of cross-linking, such as CACXL, contact lens assisted cross-linking, or other kinds of advanced corneal cross-linkings which have been described, such as customized cross-linking and so on. The other treatments which are there are ICRS and intracorneal ring segments. And I'll just go to this part of the treatment. I'll stop sharing this and just share my next screen, which is also one of the treatments. One second. Yeah, okay. So you would have all heard about ICRS, intracorneal ring segments. What this does is basically you're putting synthetic segments or I'm talking about corneal allogenic intrastromal ring segments. I do have a patent pending. In fact, I have a patent issued for these special refines. It's just recently been issued. These are my financial disclosures. And as I said, ICRS basically refers to synthetic segments which are placed within the corneal stroma. These have an arc, they shorten the corneal arc length, and they kind of stretch the cornea so that the conical protrusion of the cornea gets stretched between these two synthetic segments or plastic or PMMA segments which are placed within the cornea, and that decreases the keratoconus and also has some effect on slowing the biomechanical progression of keratoconus. It's not a definitive treatment on its own. You have to combine it with cross-linking in progressive cases. Non-progressive cases, you could use just this. But the problem with these synthetic segments was that PMMA does not do well, or any synthetic segment does not do well within the cornea, just because of the reason that it's synthetic. So it can cause corneal melts, necrosis, overriding, as seen in this case, infectious keratitis. You even got case reports of intrusion or melt within the cornea into the anterior chamber, causing a hydrops. These are my own patients. When you have a long-term follow-up, because synthetic does not do well, these are problems which are known to happen, and you often have to deal with this in many patients. So this CARES was an idea that I had in 2015. It's basically a similar technique of using intracorneal ring segments, but these are now made of allogenic tissue. CARES stands for corneal allogenic intrastromal ring segments, and you could use any source of allogenic tissue for this, don't preserved or fresh processed tissue or anything. What we do is use the donor corneoscleral rim, and I'll show you the technique. Here we have mounted the donor corneoscleral rim on an artificial antechamber. You can see what I'm doing first is removing the epithelium, because we're going to implant only stroma. We don't need epithelium implanted. So you remove the epithelium. Now you dismount the cornea from the artificial antechamber and remove the endothelium. So now you're left with just mainly the stroma and Bowman's membrane. So this is a double-bladed refine, which has got 2 blades, concentric blades, which is then used to punch this tissue, a ring of stromal tissue. And this stromal tissue is then cut. And you have something now that is similar to Intacs, but it's made of allogenic or corneal tissue. Now here is a patient where we've already created femtosecond laser dissected channels. If you look carefully, there's a cut here and there's a cut here. And the laser channel has already been created in a patient, a keratoconic patient's eye. Now what we do is we implant these allogenic segments, CARES, into the patient's cornea. And you can see, you would think, oh, how will you implant this? It's soft tissue. How will it go into such a thin channel into the patient's eye? But you can see it's easily going in. And the same thing is done on the other side. So basically, you've got now allogenic Intacs or human tissue Intacs or CARES, corneal allogenic intrastromal ring segments, which helps increase the visual acuity. and improve the topography. Now, the beauty of this over Intacs is not just its safety in preventing complications, but also the fact that you can implant it much more superficially. If you look at this, this is how an Intacs is typically implanted at 75 to 80% depth, because you're scared that this will erode out. And so you want to have a safety net of enough of stromal tissue above the Intacs. But with corneal cares, you're not worried about that. So you can implant more superficially. This allogenic tissue, biocompatible, it's not going to erode out. So we have been implanting this at about 50% depth. And so you get much better effect than Intacs. And you can go into smaller optic zones. You can implant it in smaller optic zone than Intacs, again getting a much better effect. And that's huge advantage of cares. You don't get glare and halos as compared to Intacs or other Kera rings and things. Less risk of complications, highly customized. So these are big advantages. This is an example. I'll just request everybody to mute yourself, because there's a lot of disturbance that's coming. Please mute yourself. Please, everyone who's listening, mute yourself, because there is disturbance that's coming on the line. Okay, so this is basically a patient who's undergone cares, and you can see the smaller optic zone. And you can also see the amount of decrease in topography that we've got. This was a patient who had about 72, 73 diopters of steepening, okay? And we've got it down to 40, 47. This is almost normal topography. For 41, 47, 44, look at that. The levels are normal. And we've got about 30 with 31 diopters of flattening, which you can never get with Intacs, and which we've got with cares. It's almost equivalent to having done a DALC on this patient. If you look at the Scheimpflug image, this is the preoperative image. This is a postoperative image, which has been superimposed on the preoperative image. And these are the cares that are implanted. And look at the flattening that we've got. And that gives the patient an improvement in uncorrected, best corrected visual acuity, and decreases the ocular aberrations, makes the ghosting less, and gives patient uncorrected improvement in everything, and decreases contact lens dependence and everything of that sort. So you cannot, not just in keratoconus, but also in other corneal ectasias, you can use it. For example, this was a patient with corneal melt, for whom we removed the Intacs. This was Intacs related corneal melt, as you can see here. We replaced it with cares, and we got a beautiful effect. You can still see the one single Intact still left in place, but the other side cares. And this is now being done. It was introduced in our hospital first time in the world by us, and now it's being done in all the countries around the world: US, Canada, Australia, South Africa, Turkey, Israel, Lebanon, Dominican Republic, Germany, Ireland, all first world countries. Everywhere it's been accepted in a very, very large way, and very positively, because of the obvious advantages that it gives over the traditional methods of treatment. You can avoid DALC in many cases. So this is a patient where I said we removed the post Intacs from the melted cornea, and now we have replaced it with the cares. You can see that we replace it with the cares, and then we put some sutures so that the cares just stays in place. And then post suture removal, you can see how the patient is done. So again, cares pre-suture removal, post-suture removal. A second patient where we've replaced similar complication, we have replaced the Intacs with cares. And not only did it just replace and fill up that corneal defect, it actually gave you better flattening than this Intacs was giving. Look at that difference map. This is with the Intacs in place pre-op. This is post-op. So your topography is also improved, your vision is also improved, and the patient also avoided a big complication. Not only for complications, but patients who are unhappy with Intacs, the vision associated with Intacs, you can still remove the Intacs and put in a cares. And this is a patient who was a doctor who was unhappy with his visual acuity, which he got with Intacs, which was implanted. And you can see here with the Intacs, the topography, post Intacs explantation and cares implantation. This case we implanted cares at a more superficial level than the Intacs was. So we got a beautiful reduction in the topography and an improvement in visual acuity. I think just show you some topographical improvements. You can change the type of the thickness of the cares that's being implanted to get different levels of improvement. One beautiful part about cares is it not only gives flattening in the steep axis. This was the preoperative steep axis. This is pre-op here. This was the pre-op steep axis. It gave you flattening in the steep axis, but many times it gives you compensatory steepening in the flat axis here, so that you get an overall regularization of the cornea, a centralization of the cone. Okay, and that brings down the cylinder to a large extent. So you can see here pre-op was 7 diopters and post-op was 2.5 diopters cylinder, a much better tolerable power. 2120, or rather I'll come to 636 uncorrected improved to 69 uncorrected, and the visual best corrected improved from 612 part to 69 part, and the refraction improved from -7 cylinder to -2 with -2.5 cylinder. And the patient was so happy with the visual, and of course the aberrations come down a lot. He went for the other eye also, which is a much milder form of keratoconus, and was very happy with that also. You can here see a decentered care pre-op. The decentered keratoconus, we have put in a single segment and got flattening above the segment, that compensatory steepening which you get on the opposite axis, which was the flat axis here. So an overall much more better topography and improvement in vision. I think with that, I'll come to the, there, of course, just to complete that keratoconus, there are other treatments for keratoconus, such as, DALC you can do for much more advanced cases, but in many cases, we have been able to avoid DALC completely. And you can also do a penetrating keratoplasty in the very final cases where you've got scars and all. And other than this, you can of course also give spectacles, rigid gas permeable contact lenses, or special kinds of contact lenses such as the Rose-K mini scleral prose lenses, and so on and so forth. The most important treatment, or the most take-home message that I want you to remember is, do not treat keratoconus with plain contact lenses alone, because what you're doing then is you're showing the patient a beautiful world with contact lenses, but you never treated the underlying disease, which is the pathogenesis, which is the progressive nature of the disease. So please do cross-linking for patients if they're progressive, and then only give contact lenses, because otherwise you have given beautiful vision and the patient is in a false sense of security, thinks he's doing extremely well, and then comes back a few years later with advanced keratoconus and high drops, and then you're forced to do a DALC or a PK for this patient. So just plain contact lens alone without actually trying to stop progression of the disease is not a good option. You have to first try stopping progression of the disease. That I'll come to the end of my talk. Thank you so much.
Thank you so much, ma'am. It was so informative. I hope people learned a lot.
Thanks, Vaishnavi.
Thank you, Vaishnavi. I'd like to call upon our next speaker, Dr. Bhaskar Srinivasan, who's a senior consultant of cornea and refractive services at Shankar Netralaya. And he is a teacher par excellence. And we have all seen how passionate he is about ocular surface disorders. He has multiple publications in national and international journals, in various international journals. And I would like to request Sir to start his talk.
Thank you, Preeti, and a very good evening. I would like to share my screen. Yeah. Is the screen visible?
Yes, sir.
Yeah.
Yes, sir.
Yeah. So I was asked to speak on approach to ocular surface disorders. No financial disclosures here. And basically, what constitutes the ocular surface? It's basically a conjunctival epithelium, the corneal epithelium, the corneoscleral limbus. But the ocular surface epithelium has to function in coordination with the lacrimal gland, the blink-related mechanism, the normal corneal sensations, and the entire gamut is responsible to maintain a healthy ocular surface. So like in this patient who's blinking so much because of blepharospasm, obviously the tears are also not going to be normal, and you need to address both the blink and the tear deficiency in this case. So when you look at ocular surface disease, you could have a varied presentations from a mild disease to an end-stage ocular surface disease. So an approach to an OSD is a little bit challenging because each disease needs a different approach. So basically, you're looking at a dry eye disease where you're looking at foreign body sensation, itching, burning kind of a situation, whereas you're looking at say a chemical injury where you're looking at a limbal dysfunction, where you need to know whether it is a unilateral problem or a bilateral problem. And when you're looking at cicatrizing conjunctivitis or a keratinized ocular surface, you're again looking at whether it's unilateral or bilateral, and then you need to decide whether you would want to do any keratoprosthesis. Again, it is also important in ocular surface disease patients to know whether they have any systemic issues, because a lot of systemic diseases can cause ocular surface problems. So let's go through first with dry eye related diseases. So when you're looking at a dry eye, you have the DUCE2 algorithm, which is given you how you would approach a dry eye disease. You look at the triaging questions, you look at the risk factor analysis, and then you look at the symptom questionnaire. Once you give the symptom questionnaire, you look at the homeostasis markers, which is basically looking at the non-invasive breakup time of less than 10 seconds, tear osmolarity more than 308 milliosmoles, and ocular surface staining. Based on this, then you look at grading them as whether it is evaporative dry eye or it's aqueous tear deficiency or a combination, and based on which is more prominent, you advise the treatment plan in that particular patient. The DUCE2 also gave us some kind of an algorithm to manage a patient, because we do know that there's symptom sign mismatch as far as dry eye is concerned. So if you're looking at an asymptomatic patient but who has signs on the surface, you're basically looking at probably a neurotrophic condition, and that needs to be addressed. Or you are looking at a very preclinical disease state, and if you're planning to take the patient up for a cataract surgery or refractive surgery, you would need to keep the patient primed, or you need to improve the ocular surface status before planning for the refractive procedure. Again, if you're dealing with a symptomatic patient but you're not seeing too many signs on the surface, it could be something called as a neuropathic pain that needs to be addressed. The other way of diagnosing dry eye or in terms of treating dry eye is based on the Asia Dry Eye Society, where they classified it instead of looking at hyperosmolarity, inflammation. They basically looked at only the tear film breakup and said that the tear film breakup less than 5 seconds along with symptoms is sufficient to classify a disease as dry eye. The advantage of this is it's a much more clinical definition, and it's very easy. You don't need equipments to actually diagnose it. You just need a fluorescein strip to diagnose the disease. But the difficulty is it also deals with patterns of tear breakup, which you need to keep seeing to understand better. So it has divided the dry eye disease into aqueous tear deficiency, evaporative dry eye, or decreased wettability, and it gives you different staining patterns in terms of how an ATD, which is severe, how when it is mild, and how the decreased wettability when it is severe and mild will look at. What is important is as soon as the patient blinks, if you're seeing the staining or you're seeing the staining or the pattern of breakup after a few seconds of the blink. So if you're looking at, say, an evaporative dry eye, you need to first wait for the tear film to form and then see the tear breakup spots. So more commonly, ATD in terms of the staining pattern and the line break is very easy to identify. The spot break when it is mild is a little bit challenging, but if it's very severe, it's easy to make out. And a random break is you have to actually give it time for the tear film to form before you see the random spots of tear film breakup. Again, it's very important to use fluorescein for diagnosing ocular surface diseases, and they give you multitude of information, whether it is a positive staining or it's a negative staining, and or it is for say a Seedal's positive test, or it is for limbal stem cell deficiency. It gives you a lot of information, and it is essential part of any ocular surface evaluation. So let's go through certain cases. This was a patient who had an RA who underwent a cataract surgery elsewhere. Post-cataract surgery, the patient, post-cataract surgery, the patient had a worsening of the dry eye, underwent LipiFlow. She was on sodium hyaluronate-based drops. She had, she was on topical cyclosporin. She had smart plugs, but in spite of that, the surface was significantly damaged in both the eyes. This is the other eye. So what do you do for this kind of patient? When it's so severe, you probably need to do something in terms of preserving the tears, and we went ahead and did a punctal cautery, and within a day post-cautery, the defect, which was almost there for about a month, healed significantly, and the vision also improved. So this leads us to how would you approach cataract surgery in ocular surface disease patients, and the ASCRS has actually given us a reasonable guideline in terms of how you would want to go ahead with it. So as soon as the patient comes to your clinic, if you're doing your non-invasive refractive surgery evaluation, or you're doing your cataract evaluation, you can do it, and then you do an OSD screening. If the patients have a negative screening, then you can go ahead with surgery. But if the patient has a positive screening test, then you would need to evaluate. The screening test basically involves an osmolarity and, if available, MMP9 kit. But in an Indian context, both of these are fairly expensive, and we might just rely more on a questionnaire and a clinical evaluation. And it is important to look at the LLPP, which I have ticked at the bottom, which basically means you look at the lids, you look at the lashes, you look at the interpupillary area, you lift the upper lid to look at the superior conjunctiva to look at whether there's any staining there, because that's one of the causes of SLKC. You pull the lid to look at lid laxity, and you can push the lids to look at meibomian gland dysfunction. So these are important when you assess a patient before cataract surgery as such, as far as OSD is concerned. So they give you an algorithm, again similar to the DUS2, where you're looking at symptom sign mismatch. You're looking at whether it is visually significant ocular surface disease or it is not visually significant ocular surface disease. If it's non-visually significant ocular surface disease, you could go ahead with this with the cataract surgery. But if it's a visually significant ocular surface disease, you need to address the disease and then plan for cataract surgery. So this is another patient where the patient had a flictanular keratitis, and this is normally seen with staph immune keratitis. And you can also have sterile, the bottom picture shows sterile infiltrates with the clear lucid interval without vascularization. And this is also very classical of lid margin related keratitis. We were thought that it is staph related, but now you also know that there's something called as Demodex, which causes this kind of clinical picture, and you would need to treat that or look for that, especially if you have collarettes around the base of the lashes. Then then you plug the lashes and look for demodex under the microscope. So you would treat the lid margin related keratitis with topical antibiotics, topical steroids, and you would want to treat the demodex if it is positive with lid hygiene and scrubs with 5% tea tree oil scrubs every day, and with 50% tea tree oil scrubs weekly. There are also reports of using ivermectin 200 micrograms per kilogram single dose, and it's repeated after a week's time. Again, like I said earlier, you would need to lift the lid and look at the upper conjunctiva, especially in patients who are complaining of irritation, discomfort. And if it is there, you look at the tarsal conjunctiva also, you'll normally have a mulberry-like appearance or significant papillary changes, and you will see a stained superior palpebral conjunctiva along with staining of the superior cornea also. And this is what is called as superior limbic keratoconjunctivitis, and this is after treatment with topical steroids and topical restasis, and the patient was comfortable. Again, this was a patient who had come for refractive surgery. Pre-op evaluation with respect to the dry eye test revealed the breakup to be normal. The tear meniscus height was fine, but the lipid layer thickness was on the lower side. The fluorescein breakup time was also slightly on the lower side. And this is the lippy view. You can see the pattern of interference pattern shows a more dark grayish pattern, which indicates that the lipid layer is not as thick as it should be, and the value is around 60 microns, 60 nanometers in the lippy view, and it was around 42 microns in the dry eye analyzer. So this patient, since the patient wanted refractive surgery, we have looked at the lipid layer, which is a little bit low in spite of the blink being high. There's significant partial blinks. So we first decided to treat the patient with LipiFlow, because this is a patient who has contact lens associated dry eye. We treated the patient with LipiFlow before going ahead with refractive surgery. Again, what are the reasons for problems post-refractive surgery? Is obviously the disruption of the nerves, the damage to the goblet cells, and the altered shape of the cornea post-refractive surgery, all of which can lead to tear film instability causing an ocular surface disease or dry eye, and you need to be aware of that. Again, you have something called as line, that is LASIK-induced neurotrophic staining, which occurs at the superior 2/3 and inferior 1/3 junction as a linear pattern of staining. And you also have a concept of pain without stain, because you can have neuromas in post-LASIK patients, which can be responsible for neuralgic pain as such. So this is again a patient who has who's diagnosed with severe vernal keratoconjunctivitis and also had keratoconus. So obviously, if you have a patient with VKC with keratoconus, before you do a cross linkage, you will need to control the disease process. He was put on topical immunomodulators, alloparidine, intermittent steroids, and once the disease was under reasonable control, you can go ahead with cross linkage, or if it's a severe disease, you could go ahead with LK, as the case may be. This is taken from the article in IGO by Nikhil Gokhale, where he has graded the VKC into mild, moderate, intermittent, moderate, tonic, severe, and blinding, and gives you the list of options that we have medically, where you're starting off with avoidance lubricants to immunomodulators and even systemic therapy with immunomodulators. And in severe cases like very recurrent shield ulcers with giant papillae, you might want to consider excision along with mucous membrane grafting and debridement of the plaque in terms of a shield ulcer, which might be required. Sublingual immunotherapy is also being tried in certain cases where it is associated with systemic atopy. Again, in SJS, you have something called as lid margin keratinization, which basically means that the lid margin is not as smooth as what it should be, and with each blink, it rubs on the ocular surface, causing blink-related microtrauma, which is responsible for significant corneal staining, corneal vascularization, persistent epithelial defect, and you would need to address that. You can address that either with using a Prose lens to prevent the lid margin from rubbing on the cornea, or excising it and replacing it with a mucous membrane graft. We prefer to excise it and replace it with a mucous membrane graft. And just by addressing the lid margin, you can actually see an improvement in the ocular surface status. Here in the first photo, you can't see the details of the anterior chamber as clearly, whereas in this picture, you can actually see the haze has reduced, the vascularization has reduced, and the vision has improved. Again, something which is caught our attention recently is the presence of neurotrophic keratitis, which is basically reduced and absent corneal sensations. It could be because of damage to the fifth nerve, or it could be secondary to, say, a viral keratitis. You need to know the grading of neurotrophic keratitis. I'll come to it in the next slide as such. So basically, the Mackay classification, which says grade 1 is epitheliopathy, grade 2 is persistent defects, and grade 3 is where it is involving a stromal melt. and you have various reasons for neurotropic keratopathy, basically all affecting the fifth nerve. Apart from that, systemic diseases like diabetes, leprosy, and systemic pediatric conditions can cause fifth nerve damage, leading to neurotropic keratopathy. The treatment options for neurotropic keratopathy would be lubricants for the dry eye. You could use autologous serum in certain cases. Nerve growth factors in terms of Synggermin is available now, but it's too expensive to be used in an Indian context. Specialized contact lenses like a Boston scleral lens can be tried in certain patients. Surgery in terms of tarsorrhaphy or corneal neurotization is also an option in these patients. Patient with chemical burn, and when you're looking at an acute burn, you need to grade the burn accurately, and Dua's classification is the most appropriate at this point of time, which tells us about the extent of limbal defect, extent of conjunctival defect, and you grade the disease based on the extent of limbal defect. But you need to also quantify in an analog scale the amount of conjunctival defect, because the extent of conjunctival defect finally also tells you what the prognosis in terms of that patient is going to be. The problem with Dua's classification is still that it doesn't address all factors in an acute chemical injury. It doesn't address the scleral ischemia. It doesn't talk about the intraocular pressure. It doesn't talk about exposure. And we've published our article on the I's and E's of management of acute chemical injury, where we are looking at all the factors that are affected in that need to be addressed in an acute chemical injury. You need to irrigate the surface first. For the ischemia, if it is generalized or localized, depending on the extent, you would want to consider tenonplasty. For exposure, you would want to consider lateral or a complete tarsorrhaphy along with a skin graft. Intraocular pressure, if it is low, you might want to use systemic steroids. If it's high, you will use anti-glaucoma medication. But the most important part of the management is to manage the epithelial defect. So again, if the epithelial defect is only in the cornea, contact lens alone would suffice. But if it's corneal and conjunctival, and if it's more than 50% of bulbar surface is affected, you might want to surgically intervene and put an amniotic. And if it's more than 50%, you'll probably think of doing an allogenic slit along with an amniotic to facilitate a faster epithelialization of the ocular surface. The idea of management of chemical injury in the acute phase is to prevent a stromal scarring or melting, which will then change the dynamics in terms of the long-term outcomes that we could get. Obviously, if the patient presents with melting or scarring to you, you would need to avoid a perforation by doing an amniotic, doing a tissue adhesive lamellar keratoplasty. But if it's already perforated, you might want to consider a PK. Again, when you patient like this, where your cornea looks reasonably clear, but there's a focal area where there is a lackluster appearance, and you do a fluorescein stain, and you can see the conjunctival phenotype, which is seen in the superior area, which is suggestive of a focal limbal stem cell deficiency. And basically, limbal stem cell deficiency is defined as loss of, defined as a conjunctivalization of the cornea, and there are signs of epithelial dysfunction. There is delayed fluorescein pooling on the cornea. It could be associated with ocular surface inflammation, vascularization, scarring, and an imprint cytology, if done, would show goblet cells in the cornea. And we now have a global staging of limbal stem cell deficiencies, which has been suggested, and it could either be sectoral or total. And you could have various causes for limbal stem cell deficiency. Obviously, the most common causes in our scenario is going to be chemical burns, but apart from that, it could be iatrogenic contact lens induced SJS, OCP, or in terms of congenital patients, congenital aniridia. So when you're looking at staging of limbal stem cell deficiency, a stage 1 is when the central 5 mm of the cornea is not involved, and it is divided into stage 1A, B, and C. A, when it is less than 50% of limbal involvement; B, when it is between 50 to less than 100% of limbal involvement; C, when there is more than when there is 100% limbal involvement. A stage 2, when the central 5 mm is also involved. Again, if it is less than 50%, it is 2A. If it is more than 50% but less than 100%, it is stage 2B. And when the central 5 mm is involved and 360 degree of the limbus is involved, it becomes stage 3. These are just photos showing the various grades: a stage 2A, a stage 2B, and a stage 3. When you talking about limbal stem cell deficiency, obviously you need to know whether it's unilateral or it is bilateral. If it is unilateral, you need to know whether it's a moist eye or it's a dry eye, keratinized surface. Unilateral dry keratinized surface, you are only going to be addressing a cosmetic nature. If it's a moist eye, you can do the fornix reconstruction, and then based on the status of the underlying cornea, you could go ahead with autologous slit with or without a keratoplasty in that situation as such. If it is a bilateral disease, then you are looking at whether the surface is dry, whether the surface is keratinized, and if the surface is moist, then you're looking at whether the fornix is formed or fornix is oblated. If the fornix is formed and the surface is moist, you can try fornix formation. Once the fornix is formed, then you can probably look at either a stem cell based treatment or a keratoprosthesis based on the feasibility of putting the patient on systemic immunosuppression as such, because since both the eyes are involved, you would want to do an allogenic stem cell transplant. If the fornix is not forming in spite of multiple efforts, or if the surface is dry, then you would want to consider keratoprosthesis only. And if the surface is significantly dry or keratinized and the fornix is bad, then you are looking at a type 2 keratoprosthesis, where you have the option of either the MOKP or the osteokeratoprosthesis or the Boston type 2 keratoprosthesis. So to conclude, each ocular surface disease is different. A detailed history, especially a fluorescein staining, helps us to identify and ascertain the extent of the damage. A specific algorithm is required to manage each type of disease. Pre-refractive surgery assessment of ocular surface is essential. And if you have a patient with severe OSD, it might be better to refer it to a cornea specialist or to an institute. Thank you.
Thank you so much, sir. I think you have decoded ocular surface disorder to us in such a lucid manner, and I'm sure all the PGs have benefited from this. Thank you so much, sir.
Thank you. Thank you.
So going on to our next speaker, we have Dr. Shushma Tejwani. She's a head of cornea glaucoma services at Narayan Nethralaya. She's an ex-fellow from LV Prasad Eye Institute, and her field of interest is glaucoma surgeries, including shunts, pediatric glaucoma management, and refractive cataract surgeries. She has a keen interest in clinical research, especially pertaining to glaucoma diagnostics and corneal biomechanics. She has presented various papers in national and international meetings, and I'd request ma'am to start her talk now.
My screen is visible, right?
Yes, ma'am. We're able to see it.
Good evening, and thank you for the kind introduction and the opportunity. I'll be just talking about glaucoma workup today. So in addition to what we routinely see, the components that are necessary for glaucoma is what I would cover. So we know as a definition of glaucoma that it is chronic progressive optic neuropathy with typical changes in optic disc, that is retinal nerve fiber layer, with corresponding field effect. Intraocular pressure is not important for diagnosis, but still considered a major risk factor. So basically, we look at the combination of raised intraocular pressure, disc changes, field effects as glaucoma. And of course, gonioscopy plays an important role to diagnose type of glaucoma so as to manage. We need to have an unbiased collection of each clinical finding and interpret the findings in correspondence to each other to be able to reach to a diagnosis, and also meanwhile appreciate the limitations and pitfalls in each of these findings. Now let us go one by one. Intraocular pressure, as I said, is very important, and there are different tools through which you can measure. However, our Goldman applanation tonometer still remains the gold standard. So that's the best way. The other ways are in situations where there are children, non-cooperative patients unable to sit on slit lamp and things like that. So what is the role of IOP? Well, what is normal? We consider the 2 standard deviations on either side of the mean as normal. The absolute value of IOP is not diagnostic. However, higher IOPs are associated with a higher risk of glaucoma. So, and we also know that significant number of glaucoma patients do have normal presenting intraocular pressure. So to minimize the variability in measurement, we have to have a mean of 2 consecutive readings at each measurement. And if the difference is more than 2, we may consider taking a 3rd reading with a median of 3 readings. So it is important also to take multiple diurnal measurements because it's a dynamic value. It's not constant. And also we need to understand the influence of central corneal thickness. So that is important in measurement. Coming to gonioscopy, well, the gonioscopy is important not only for diagnosis. We cannot diagnose a patient of open angle glaucoma also without gonioscopy. It is also important to prognosticate, especially in situations where there is, angle closure, progressive angle closure, or there is neovascular glaucoma. So we have to see on the follow-up also that how these are progressing, and based on the findings we can prognosticate the patient. There are a lot of therapeutic approaches that are through gonioscopes. The lasers, ALT, SLT, and a lot of MIGS implants that we do require intraoperative gonioscopy. So there is definitely an important role. So all of us need to understand why, how to assess and look at the angle in any patient. The diagnosis of unilateral glaucoma is also established by only, sorry. So I'm taking you through a technique now.
Indirect gonioscopy is for mirror that has the contact surface smaller than corneal diameter, whereas this is the two mirror lens that has concave surface and is larger than the corneal diameter. To perform gonioscopy, position the patient appropriately on the slit lamp, examine the ocular surface, and note the condition of the optic nerve with undilated pupil. Explain the procedure to the patient and instill the topical anesthetic drop. For the two mirror lens, use lubricating drop as the coupling agent. Hold the upper lid, ask the patient to look down and insert the lens. Then magnification can be increased to see the angle. For the 4-mirror conio lens, hold the lens in front of the cornea and then move closer as you make contact by keeping a watch on the tear film. Once the tear film is evenly distributed, the view of the angle is clear. First objective of performing a gonioscopy is to look at the occludability of the angle. Gonioscopy is first performed in a dark room with a small light falling on the angle so that pupil may not artificially open the angle due to light reflex. Once the angle is observed 360 degrees in this condition, the light can be increased and the slit beam can be enlarged so that the light falls on the pupil and opens up the angle. To identify angle structures, it is important to identify the Schwalbe's line, and that is done by making a thin slit beam and oblique illumination on slit lamp while performing gonioscopy. In superior or inferior mirror, one can observe collapsing of the light beam that illuminates Descemet's and Bowman's membrane. As the Schwalbe's line denotes the end of Descemet's membrane, the light no longer passes through the opaque structure beyond Descemet's and causes the collapsing of this beam. And this is called corneal wedge sign. The place where these two beams convert into one is the Schwalbe's line, and posterior to that are the rest of the angle structures. This angle represents the normal open angle in an individual. This particular angle shows narrow entry with only Schwalbe's line visible with a small light. However, with indentation, the angle opens up, thereby suggesting appositional closure. Here, one can see patchy pigmentation of the posterior trabecular meshwork, which is indicative of signs of prior occlusion. In certain angles, you can see goniosynechiae at one or multiple places. If the angle does not open despite indentation, that suggests synechial closure.
So that is why the diagnosis is based on gonioscopy. You can differentiate into PACS, PACG, and POAG and plan the management accordingly. The peripheral iridotomy and medical management is decided on the basis of that. Certain pictures showing you pseudo-angle and pseudo-synechiae, so you have to be aware of those things. You should indent and see to understand whether it is an angle closure and the pigment giving you a false appearance of PTM, or it's a pseudo-angle, pseudo-synechiae, which opens up on indentation. Plateau iris looks like that. You have a convex configuration of the iris close to the limbus, and rest of the signs of angle closure is classical of plateau iris. This is IC syndrome. This is a black ball denoting old hyphema. This is an angle recession, and this is a glass foreign body in the angle. And this, you can see a silicone oil in the angle. Pigment dispersion syndrome can also be identified with a concave iris configuration and a lot of pigment in the angle. Iris cyst can be picked up on angle and can be confirmed on UBM. This is cyclodialysis picture, and this is a vitreous blocking the internal ostium after trabeculectomy. The next is optic nerve and the visual field. Now, why I say that those are also important, according to the EGS guidelines, if you look at this framework of diagnostic criteria, you can see optic nerve head is an important thing. When it is abnormal, it is considered glaucoma, and visual field abnormality is also considered important in suspect cases. So in addition to the IOP. So optic nerve is the next important thing that we need to understand and learn the master the technique of looking at it in the clinic. So here again, you have to position the patient properly so that you can see this thing well. And for the undilated gonioscopy, you have to take the retroillumination, focus onto the cornea, interpose the lens, and pull the joysticks towards you till the time you see the optic nerve or the retina. Once you've seen the retina, focused on that retina, you can move the joysticks horizontally to look at the structure. You can widen the beam to have a better view, so that you can have a better judgment of, say, CD ratio or other important things that you need to look at the optic nerve. Dilated examination gives you a very good view. So all patients of glaucoma, whether it is open angle or angle closure post PI, you should have a dilated disc evaluation to have a fair idea how the optic nerve looks like, so that you can pick up earliest changes. So the optic disc features in glaucoma, these are the things that we need to look at. Well, always remember that optic disc size is important along with the CD ratio. On its own, it doesn't mean anything. So if there's a small disc, even the CD 0.5 is also abnormal. If it is a large disc, the CD 0.7 is also okay. So you have to keep in mind the size of the disc when you're describing a CD ratio. CD asymmetry is a very important factor. You can see in this particular example, right eye has a larger CD and the field effect, whereas left eye is normal. Neuroretinal rim is what we are interested in when we are looking at optic nerve. So we need to understand, when we make a cut section of, say, optic nerve, the normal neuroretinal rim should look like that. When there is a backward bowing, it is called saucerization. And when there is sloping, that is where we see loss of neuroretinal rim and subsequently the notch. And these are the things that how it looks clinically, each one. That was a diagrammatic representation. So you have to keep in mind to examine the neuroretinal rim properly. Like this example, the large disc, however, if you look at, the inferior rim is lesser than the superior rim. So there is a problem in the neuroretinal rim there, and you see a corresponding superior defect there. The localized NFL defects are very, very important and sensitive, specific signs of glaucoma. If they are present, that is very specific of glaucoma, and you can see in this particular picture, and a corresponding field effect. The disc hemorrhage is again a very specific sign of glaucoma, although the sensitivity is less because it stays for, say, 10 to 35 weeks and then disappears. More common in normal tension glaucoma. So an isolated disc hemorrhage close to the disc without other retinal hemorrhages is what is important. Myopia, you have to be very careful because there are certain changes that overlap. For example, if you see, this is the right and left eye of a patient who is myopic, and these are the visual fields. Now you have to be careful that this is the enlargement of blind spot and not glaucoma. This is due to myopia. Well, as I said, the optic nerve head and then the function is also a very important thing. We need to look at both anatomy and function of the optic nerve to diagnose glaucoma. Well, I'll just in brief touch upon perimetry and ONH because we don't have much time to describe everything in detail. So when do we do perimetry? When there is clinical suspicion of glaucoma, high IOP, we suspect a disc and there is primary angle closure. To establish the diagnosis of glaucoma, patient who is on treatment for glaucoma with no recent baseline functional assessment and repeat for baseline if unreliable or do not correlate with clinical findings. Also on follow-up while managing these patients. The printout, as you know, is divided into various zones. Zone 1 is patient data, and zone 2 gives you reliability indices. So you need to be careful about whether the test done is reliable or not. 3 gives you a raw data scale, and 4 gives you a gray scale. Zone 5 is a total deviation plot that tells you the deviation from the age-related normals, whereas the pattern deviation plot, zone 6, numeric as well as grayscale, tells you the irregularity within the field. That means the focal defects get highlighted there. And finally, zone 7 gives you the global indices in terms of VFI, mean deviation, and pattern standard deviation. And zone 8 gives you the glaucoma hemifield test. So these are all components of printout that we need to look at. Just to give you an example, if this is a normal hill of vision, that is how the field would look like. Both total deviation and pattern deviation plot are clear. When there is generalized depression, you will have a lot of points abnormal on the total deviation plot and clean pattern deviation plot. Whereas if there's a localized depression like this, you will have similar defects on both total and pattern deviation plot. And if there is a combination of generalized and local depression, then you will see more points on total deviation plot and also involvement of the pattern deviation plot. Some examples, you can see there is a superior notch here, and you can see the inferior field defect. You can see superior, inferior NFL defect and the biarcuate scotoma. However, we should not get carried away only by the field defect. We always need to look at the nerve. Say, for example, this one looks like a superior arcuate, but this is due to choroidal coloboma. This is a myopia, as I showed you earlier, enlargement of blind spot. Sorry. Okay, and this is an inferior arcuate change, which is related to actually a vein occlusion. So our dilated disc evaluation along with the field is definitely important. We should not depend on the fields alone. Imaging is essential to diagnose pre-perimetric glaucoma, and if patient is unable to perform fields, or if perimetry is not possible due to any reason, it is desirable in patients as a baseline for mild and moderate glaucoma and for follow-up to look for progression. It is not required in advanced glaucoma because of the floor effect. So this is a print. This is how a printout looks like. So this gives you a patient identity, image quality, and centration. Before you go on reading, you should look at these things. Then this one gives you a thickness map for RNFL that is color coded, and this gives you a deviation map as compared to the age-related normals. At the bottom of each, the color coding patterns are given, so it's easy to pick up. This is a red-free image to pick up RNFL defects. This gives you the average thicknesses, and this is an RNFL thickness values in 12 clock hours, and this is a TISNET graph, and this gives you the ONH parameters. Now, and the rim disc ratio. So what is important to understand that a thickness map and deviation map should be correlating with each other. Their color codings are opposite. So you need to look at that this is a comparison with normative database, and this is patient's absolute thicknesses. Secondly is the RNFL thickness map. So this TISNET black graph gives you the your patient's data. This falls in green, yellow, or red, determines whether it is normal, borderline, or abnormal. And these are clock hours value, again given in form of a color code so that you understand that which is normal and abnormal. The optic nerve head analysis in terms of nomogram is determined by looking at the nerve width at the disc and disc diameter. So it gives you a cup diameter as well as the rim area and the various readings. You can see the measurements so as to reach to a diagnosis. GCC is another thing that we've started doing, where because the ganglion cell complexes lie in the central 5 mm of the cornea. Here again, you have thickness map, deviation map, and significance map, which in color codes give you a clear value that how much different it is from the normal and how much statistically significant it is in terms of abnormality. So it's easy to pick up. Just one slide on what is the additional workup you need to do if you see a glaucoma patient with normal pressure. You should depend on multiple readings, maybe do a full day DVT if possible. You need to understand history and systemic evaluation is important because blood flow may play a role. You should check the systemic parameters of that patient and also rule out the neurological issues and one-time ischemia. Check for history of sleep apnea, Raynaud's phenomena, etc. so as to treat the patient as a whole to treat these conditions along with glaucoma. At the end, I would like to say that diagnosis of glaucoma is based on structure and function of the optic nerve along with IOP and should not be based on a single test alone. The sophisticated test and data points should not bias our clinical judgment. It is always important to correlate clinically. And the gold standard for diagnosing glaucoma is actually a well-trained clinicians. That means all of you who can integrate the clinical findings, functional change, anatomical change, and risk factors, and then customize the patient's treatment for any given patient for that matter. Thank you for your kind attention.
Thank you so much, Dr. Shushma. And there were wonderful pictures, and I'm sure the PGs would have enjoyed the presentation. Thank you so much, ma'am.
Thank you.
Our next speaker is Dr. Sirisha Sendil. She is the head at VST Center for Glaucoma Care in LV Prasad Eye Institute. She's presented over 60 papers at national and international forums, and she specializes in managing refractory adult glaucoma and pediatric glaucoma. Welcome, ma'am.
Thank you. So can you hear me and see the slides, please?
We can hear you and see the slides, ma'am.
Great. All right. So that was a really very comprehensive evaluation and diagnosis of glaucoma, what Dr. Sushma had just spoken about. Once we know that the glaucoma is diagnosed, majority of the patients are treated medically. Now we are looking at how do we manage the patients with glaucoma medically. So before going into that, what we need to understand is glaucoma is a chronic disease and it affects the optic nerve, and we know that it is progressive, and once the damage occurs, it is irreversible. And of all the factors that we know that contribute to the pathogenesis of glaucoma, there are mechanical factors like elevated intraocular pressure, decreased vascular supply, or biochemical factors. There's so many other things that we look at in the pathogenesis, but only a treatable problem until now that we are able to help is controlling the intraocular pressure. So the various therapeutic options that we have are basically directed towards controlling the intraocular pressure. So they are medical, laser, and surgical options, and medications are the ones that are used more than 80% to 90% of the cases, because medications are, at least today's day and age, we do have good medications that can control the intraocular pressure in majority of the patients. In certain situations, lasers are used, be it open angle where a laser trabeculoplasty is done, or an angle closure glaucoma where peripheral iridotomy is a must. And surgical options, there are various surgical options that are available. What is very important is for us to understand that the goal of glaucoma management is to treat the disease in such a way that intraocular pressure or other parameters that we looked at, which is what Dr. Sushma also just alluded to, especially in patients with NTG, whatever we do, we have to make sure that the visual function of the patient is maintained for their lifetime. That means the patient doesn't go blind during their lifetime. Therapy definitely should not affect the patient's quality of life, or it would least affect the patient's quality of life. So what is important before we go into the class of drugs and how do we treat is to understand the mechanism of glaucoma. That is where gonioscopy plays a very, very important role. So mechanism of glaucoma is very important for us to understand how do we treat and what drug would possibly help in the reduction in intraocular pressure. For example, if you have a plateau iris syndrome, pilocarpine would be the first drug of choice compared to any other class of drugs. On the other hand, if it is a typical open angle glaucoma, where there are no other contraindications, especially the viral keratitis and things like that, prostaglandin analogs is the primary choice that we normally choose. So mechanism of glaucoma becomes very important for us to decide on which type of medication do we use. Amount of intraocular pressure reduction or the level of IOP reduction is very important, and also depends upon the rate of progression and compliance of the patient. So looking at various anti-glaucoma medications that are available now, so pilocarpine and timolol were the earliest ones, and now we have all the other additional medications that are there. This chart actually does not include the newer medications, which I will be showing you in the subsequent slides. So the commonly asked questions are, once we decide on treating the patient, how do we choose a medical treatment? So look at the efficacy of the drug. What is the dosing of the drug that you're going to use? Look at the patient's systemic factors, whether there are any side effects or contraindications of the medications. Are there local contraindications for the medications? And does the patient actually have some other pathology where we would not be able to use those medications? And if you have to give a combination medication, whether they are going to be synergistic or not. So how do the medications work? So basically we understand that aqueous is produced by ciliary processes, and from the posterior chamber, the fluid reaches the anterior chamber and flows out through the trabecular meshwork. That is the conventional outflow pathway. And there is also another outflow pathway, which is the non-conventional one, which is the uveoscleral outflow. All the medications that we use either work by decreasing the inflow or the production of the aqueous or increasing the outflow. So these are two basic mechanisms by which they have to work. And of the outflow drugs that affect the outflow, they could either be a increase in the trabecular outflow or the uveoscleral outflow. So these are the drugs that are conventionally used. Principles of medical management, I think one should remember that first line drug is, like I said, we use prostaglandins are commonly used. That is because the dosing is less, and more importantly, they are most efficacious. followed by topical beta blockers, and usually the alpha agonist topical carbonic anhydrase inhibitors could possibly the second line drugs or third line drugs, and pilocarpine again second or third line. But having said that, we need to remember, based on the indication or the condition that we are treating, what is second or third line could also become first line for those patients. So that's something that is very important. I'm not going to the details of this graph, but what is important is that we need to remember the duration of action of the medication based on which it is dosed. For example, if it is a 12-hourly duration of action is 12 hours, then we use it twice daily. If the action is 24 hours, then we use it once daily. So the number of times of usage of medication depends upon the duration of action of the drug. And also we need to remember there's the other topical and systemic side effects that one has to keep in mind before we decide on whether we use those group of drugs or not. A commonly used term as far as the medical management is concerned is the target intraocular pressure. So many times people ask you what a target intraocular pressure is. The definition is very simple. What we say is, in glaucoma, whatever damage that happens to the ganglion cells and loss of ganglion cells leading to a progressive loss in visual field, that has to be arrested. Some changes do happen as we grow older. Some amount of loss of ganglion cells does happen. That is equivalent to age-related damage. So basically, a target intraocular pressure is the IOP at which the damage or loss of the neural tissue is equivalent to the age-dependent loss. In other words, the progressive loss due to glaucoma is prevented. So that again depends upon the severity of the disease and whether the disease is stable or progressing. And this intraocular pressure is usually a dynamic range. Well, what I mean by that is, if let us say, if a particular patient had a target intraocular pressure of 14 to 15 millimeters of mercury in the recent time, if the patient had progressed, then I would possibly want to bring down the target intraocular pressure lower than what it was. So that is a very dynamic one. It also depends upon the age of onset. If the disease is occurring at a very young age and has an advanced disease, then we may want a lower target intraocular pressure compared to somebody who is elderly and has a very early disease. So it has to be a tailored approach depending upon the target pressure, health status of the patient, life expectancy, and also most importantly in our country, affordability and compliance. And we remember that when we use combination medications, the compliance definitely improves, because the too much of a dosing or too frequent dosing can become a very difficult medical schedule for the patient to follow. When the first line drug doesn't help or is helping, but it's not as effective as what you require, or the target IOP is not reached, then we may have to add medications. If the medication doesn't work at all, or if the patient develops complication or the side effects, then we may have to switch therapy. So this is something that we have to remember as we are treating. Combination therapy usually choose drugs that have a different mechanism of action, and they are synergistic rather than using same mechanism. And a combination therapy in a single bottle possibly also helps the patient to use the medication much better. This is something that we always have to tell the patient: apply the drop and keep the eye closed and keep the punctum occluded. The systemic absorption goes down by almost 80% when we do this technique. So it is important not just to treat them medically, but it's very important that these patients actually follow your prescription well and continue to use your medication. So how do we improve that, which is a major issue in any chronic disease? Involve the family, educate them, tell them that the treatment is not going to make a difference in their vision. That means visibly they will not find any difference, but it's going to halt the disease progression or prevent them from going blind. And the treatment is required lifelong. And if there are any side effects that you are anticipating, we should always tell the patient so that they're not worried about it. Even simple thing like redness in the eye, for us it may be something which is not very important, but for a patient, just that side effect is enough to stop the drug. So, and what is our specific aim of treatment? All these things, when we explain, the compliance generally improves. So it's also important to make sure that if they have very advanced glaucoma, visual rehabilitation becomes a part and parcel of their treatment. So just to give you an example, a young patient, a 65-year-old lady with IOP of 18 millimeters of mercury is hypertensive on treatment, has family history of glaucoma, CCT is on the lower side. You see that there is a superior rim thinning and a disc hemorrhage present, and patient's visual field also shows an inferior nasal defect. So this possibly falls into a category of, definitely there is glaucoma, possibly a normal tension glaucoma, but what is very important, what I would like to highlight here is this patient is on antihypertensives and possibly on oral beta blockers, because of which the intraocular pressures are lower. These are the newer drugs that have come into the market: latanoprostone Bunod, the Ropressa or the Netasudil and Ripasudil, and also a combination of Proclaton, which is available in the US. But with us, we have Ropressa as well as the Netasudil and the Ripasudil. So just briefly, this usually Netasudil is once daily application, increases both the trabecular outflow as well as decreases the aqueous production. Congestion is a serious problem. We don't have latanoprostone Bunod, but that actually helps to increase the uveoscleral outflow as well as increases the trabecular outflow. And a combination of both are also available in the West, and we don't have it yet in India. I'm sure in the next couple of months we should be having them. Always remember that intraocular pressure we may have to adjust based on the CCT. We know that Dr. Sushma just now alluded to, thin corneas underestimate the intraocular pressure, thick corneas overestimate the intraocular pressure. Ultimately, it is the IOP that we are treating, and we have to be very cognizant of that. So some side effects I just wanted to show. This drug, the periocular dermatitis, is caused typically by brimonidine, either as a single drug or in a combination. Sometimes they have severe allergy that looks like conjunctivitis. It's very, very important for those who are on topical anti-glaucoma medications for us to understand the way these present as side effects, and they have to be treated appropriately. And this is the same patient who was allergic to so many medications. Ultimately, we had to operate the patient, and once operated, the ocular surface really improved significantly. So that is something that we need to know. Drug-induced allergies sometimes can present just like conjunctivitis. Pediatric cases, we have to be careful about using alpha agonists and PG analogs. Topical CII and beta blockers are the commonly used ones. So to summarize, IOP lowering is definitely effective in the management of glaucoma. So the different types, groups of medications that are available is something that one needs to be aware of. Always try and establish a target intraocular pressure, which is a range and a dynamic one. PG analogs provide better diurnal IOP control and decreased dosing, so they have better compliance and persistence. Consider combination therapy that helps to decrease the side effects and improve compliance. Achieve a target pressure with the minimum medications and beware of the side effects the patients have. Do not hesitate to move on to surgery, especially if either the target pressure is not achieved or they have severe allergy to the medications. Thank you so much for your attention.
Thank you so much, ma'am. It was so well articulated, and I really hope everyone paid attention. Lots to learn. Ma'am, there's a question in the chat box, if you don't mind. Dr. Santosh Philip is asking which anti-glaucoma is safe in pregnancy.
Yeah, so in fact, I had all those slides, but in 15 minutes, I could not cover everything, so I just hid them. Yeah, in pregnancy, again, Dr. Santosh, it is dependent on the trimester of pregnancy. So in the first trimester, brimonidine group of drugs is safer. In the second trimester, most of the topical AGMs can be given. What should be avoided is in the first trimester, possibly prostaglandin analogs, topical. Again, there is not much of evidence, but there is one isolated case report that said that there was some evidence of miscarriage in one patient among those that they had noted. And of course, oral Diamox is not something that you will give in the first trimester. Second trimester, like I said, most drugs are safe. When it comes to third trimester, brimonidine should be avoided. That is because during the delivery as well as immediately postpartum, when the baby is being fed, the drug can go through the breast milk, and that can cause some amount of apnea and excessive sleepiness in the baby. So that's something that we want to avoid.
All right. Thank you so much, ma'am. And thank you for your patience as well. Yeah.
Thank you. Thank you.
Our next speaker is Dr. Murli Ariga. He is the director and a senior consultant at Swami Eye Care and Chennai Glaucoma Foundation. He has more than 34 publications in peer-reviewed journals and is avidly involved in glaucoma research as the principal investigator in many clinical trials in India. Thank you, sir.
Yeah, thank you. Good evening. And yeah, it's a nice program, and I'm actually enjoying the rest of the talk. And I'm going to give you an overview of the surgical management of glaucoma. Obviously, as the other speakers pointed out, we can't do justice in such a short time, but I'll try to do whatever I can. The traditional sequence of management of glaucoma has been medication first, so lasers next, surgery as the next the third option, and finally, when nothing else works, you go in for cyclodestruction in painful blind eyes, uncontrolled glaucomas, refractive glaucomas, and so on. Lasers such as laser trabeculoplasty or even surgery can be offered as a primary therapy in very few situations currently. So most often we would offer medication, going for lasers or trabeculoplasty or something like an open angle situation. And then surgery when nothing else works, uncontrolled glaucomas, intolerance to medication, cataract with glaucoma, and so on. So the goals of surgical management primarily is to have the minimum complications, good long-term intraocular pressure control, and have what we call as a stable visual function and don't allow the disease to progress further. And when is the surgical intervention indicated is when you have documented evidence of progression, despite whatever we are doing as far as medication is concerned. And when compliance adherence is poor, and also at the same time drugs are not tolerated or side effects are coming in, or for some reason you have to operate for cataract as well. So combined surgery is an option. In angle closure glaucoma, you would probably do the iridectomy first, peripheral iridectomy using a YAG laser initially. Relieve the pupillary block, and suppose the pupillary block is uncontrolled, the pressure remains very high, and you have extensive peripheral anti-synechiae of say more than half the angle, then you would actually even consider in this situation doing glaucoma surgery. So the estimation of the risk of progression, the physical quality of the patient's life and what he's actually expecting from treatment, the life expectancy of the patient, and choosing any particular surgical procedure, the target pressure must be decided and defined. An informed consent is taken regarding the nature of the procedures, is it trabeculectomy, or is it a combined surgery, or is it a glaucoma drainage device, or what is the method of surgery, what type of surgery, keeping in mind all the determinants of its success, complications in any given patient, and always have the patient partner you in the treatment. You are not imposing any kind of a treatment on the patient until the patient and their attenders understand the procedure, the risks and complications involved, the surgical success, and which method would suit which patient. A younger patient would be quite different from somebody who is much elderly and has cataract as well. So this has to be discussed, and not every procedure would suit every patient. Trabeculectomy has been the so-called gold standard of glaucoma surgery for many, many decades now. It was introduced first, the initial form of trabeculectomy was introduced by Keynes way back in 1968. Still remains the gold standard for most of us as a fallback procedure when medication doesn't work enough. A partial thickness scleral flap is raised, and what it does is under the partial thickness flap, we make a small opening called subscleral sclerectomy or a trabeculectomy, the area in which the aqueous is allowed to percolate from the inside of the eye to the outside of the eye under this filtration called a guarded filtration. So it's not a full thickness procedure, it's a partial thickness procedure under a scleral flap and allows the aqueous to percolate to the subtangential space, which is why the intraocular pressure comes down. And of course, you see what is called as a gleb. The wound healing is a big problem in trabeculectomy. As I said, you're creating a subconjunctival space where the aqueous is draining out. The wound healing at the conjunctival and the episcleral pain in particular is a limiting factor for the success of trabeculectomy. So antifibrotics like mitomycin C and 5-fluorouracil have been widely used for wound modulation to improve the surgical success, inhibit the healing, and allow gleb to remain formed. While antifibrotics have improved surgical success, this has come at a cost of increased complications. So we need to titrate how much to use and when to use and whether to use antifibrotics and drugs like mitomycin and so on. You can have a rough indicator of the risk factors. This has been published, and so many other textbooks and publications will give you the score, the concentration of mitomycin, and the exposure time would determine how risky the mitomycin is in a given procedure. And in somebody with a neovascular glaucoma, the score is very high, so you use a higher dose of mitomycin. Whereas if a relatively lower, what we call as a risk, you would consider much lower dose and concentration and exposure of mitomycin. Mitomycin can be applied both as a sponge method, or now I sometimes even give it as an injectable mitomycin. I'm going to show you a very brief video clip of how the surgery is done. This is a Phonics-based conjunctival flap. A triangular scleral flap is made, partial thickness, and the video is edited to make it quicker and in the interest of time. The partial thickness flap is usually about 1/3 thickness or less than half. And this is being combined with the cataract surgery in this particular situation. It's a relatively old video. You'll find that the rhexis and the hydrodissection, the phaco goes on in the usual way. And combining cataract and glaucoma surgery has the advantage of improving the vision as well as controlling intraocular pressure. But of course, the procedure in which trabeclectomy alone is done actually seems to work better when IOP is the main concern. So deciding which procedure to do first in a given patient actually depends on your judgment of how much cataract and how much glaucoma. Advanced glaucomas, you would prioritize the glaucoma. So cataract is more, you would consider cataract as the main procedure. Mild glaucomas, cataract alone may actually help. There you can see the trabeclectomy being done using the Kelly sponge. Make sure that tissue comes out clean. And the iridectomy is an extremely important step. You must make sure that the prolapsed iris is adequately cut and abscessed, and make sure the iridectomy is done in such a way that you have the iris falling back. Also, at the same time, make sure that a releasable suture is a very useful option here. You can see a single apex releasable suture here, which can actually control the pressure post-operatively to titrate the intraocular pressure. Ologen is another agent which has been used in the past. Nowadays, it is not so popular. It has also become expensive. It can be considered as an agent or a drug or a device or an implant, which actually retards the healing process and helps form the blood. Ologen has also been reported in the past. Most of us now don't use Ologen because of its cost and availability. And once the trabeclectomy is done and you have a good bleb like this, a diffuse, relatively avascular sort of bleb with not too much of vascularity and microcystic changes is the ideal bleb. So in a bleb, you must assess the height of the bleb, the horizontal extent of the bleb in clock hours, the vascularity and how vascular is it related to a scale like this. And of course, very extensive vascularity usually means that you have some problem with the bleb fibrosis. You should also check by a Seedl's test whether there's any leak and whether the conjunctiva is very thin in certain areas. So a bleb assessment post-operatively actually is very important to assess the function and success of the bleb. Complications of trabeclectomy include, I'm very briefly listing some of them: shallow anterior chamber, overfiltration, hypotonia and related complications like choroidal detachment and so on, bleb complications like blebitis, bleb-associated endophthalmitis, cataract formation many years after the trabeclectomy is somewhat common. About 50% would probably develop a cataract in the next 5 to 8 years if you do trabeclectomy alone. That has to be kept in mind. And of course, the chance of infection is always there in any surgical procedure. So it's not without risk and complications. You must keep this in mind and discuss all these considerations before you embark upon surgery. This is for the more coverage of knowledge of what has been done in the past. A deep sclerectomy involved first a superficial flap, then a deep flap, removal of the trabecular descemet window, and then you excise the deep flap. This was how deep sclerectomy was done in the past. It is no longer popular now, but it used to be a procedure in which for people who didn't like to do filtration procedure, didn't like blebs, a deep sclerectomy was an option in the past. For congenital glaucoma, I'm going to talk very briefly. Treatment is essentially and primarily surgical. If you have clear media and you're able to see the angle, goniotomy is an option. Here you see a surgical gonio lens and goniotomy being performed. When the media is not so clear and you really want to reduce intraocular pressure, the standard has been doing trabeculotomy using the Harm's trabeculotome. You identify the Schlemm's canal, you identify and pass the Harm's trabeculotome in this manner, both on the left side and the right side. And sometimes it is combined with a trabeculectomy called trabeculotomy. That has been an extremely successful procedure in most of our surgeons' hands, and that has been the procedure of choice for most of the congenital glaucoma. Now coming to what is called as minimally invasive glaucoma surgery. This is becoming extremely popular nowadays in the West as well as even in India. There is no single accepted definition of MIGS. It is characterized by an implant or a procedure to lower the IOP with very little or no conjunctival or scleral dissection. Minimal surgical trauma, fair IOP lowering efficacy, relatively safer as compared to the other surgeries like trab or drainage devices, and a very rapid recovery, minimal impact on the patient's quality of life can be combined with cataract surgery, phaco surgery. So you can increase the trabecular outflow with devices like the iStent, trabectome, GAT, and laser trabeculotomy. You can do a subconjunctival filtration with implants like the Zen implant and InFocus and microshunt and so on. You can have a suprachoroidal shunt like CyPass, which is not available now, the iStent Supra. You can decrease aqueous production using high-intensity ultrasound or using a micropulse or cyclophotocyclation. These are all methods in which you can do so-called minimally invasive glaucoma surgery without doing a trabeculectomy. The procedures which target the trabecular outflow include currently 3 devices called the iStent Inject, and the Hydrus. These allow direct access to the aqueous from the anterior chamber into Schlemm's canal. But the limitation is that the post-op IOP cannot fall below the episcleral venous pressure, and episcleral venous pressure may be elevated in some glaucoma patients. This is the iStent and this is the iStent Inject. I'm not going to show you the video in the interest of time. It's a very small device, and even two iStents can be injected in the same sitting through one injector. That's how it is available now. I will bypass the video. The Hydrus microshunt is a so-called intracanalicular scaffold, which is kept like this and actually goes into the Schlemm's canal, keeps it dilated in the nasal quadrant, allows the aqueous to bypass the trabecular meshwork through multiple collector channels. This is difficult to do, but it's actually a very elegant and a procedure which is probably worth looking at in the future. Ab internal procedures without an implant include all of these. This one is called the GAT, which has become quite popular even in India. This is called gonioscopy-assisted transluminal trabeculotomy. You have the trab 360, you have the trabectome, and you have the Kahook dual blade. I'll show you some of them. This is the GAT, which involves using a Brolin switcher, threading it from inside the eye, looking at it from the surgical gonial lens, passing it into the Schlemm's canal, and removing it 360 degrees. The Kahook dual blade is a very interesting device. It is devised by Malik Kahook. I will show you a video clip of how it is done. It's a very elegant technique. It is also currently now available in India, and it is an expensive device, but a very elegant method of removing the trabecular meshwork. It has a sharp tip with a taper and allows for a smooth entry of the blade through the trabecular meshwork. Basically, you need to fill the anterior chamber with a viscoelastic. You need to deepen the chamber. Need to tilt the patient's head and have an appropriate microscope, which is also capable of tilting, and have a surgical gonial lens, view the angle, the surgical gonial lens and appropriate gonial lens. Now you do have the disposable surgical gonial lenses as well. And once the KDB blade is inserted into the eye, this is the picture which will show you how the KDB actually works. And you can see the tip of the blade, there's a platform, the heel of the device actually fits into the Schlemm's canal, the base of it. And as you move it, you can start removing the trabecular meshwork. It's very nice to see, and it's quite relatively easy to do once you get the hang of it. This is the Kahook dual blade. The other device is somewhat similar to what I showed you. It's mechanized and probably has something like how we use a vitrectomy. This is a trabectome, and this is called goniectomy. You can see the pictures before and after the removal of tissue with the trabectome. Procedures which target the suprachoroidal space are the iStent Supra, which is almost awaiting FDA approval and nearly FDA approved now, which is probably another interesting device, which actually has to be done by inserting the device into the suprachoroidal space. So MIGS, we have 2 other devices which are also coming into the market and probably show some promise. It's moderately invasive, I would call it, they're not minimally invasive. It uses subconjunctival filtration, mitomycin can be used, but it is somewhat similar to trabeculectomy. The Zen is a gel stent made of porcine, collagen, and strengthened with glutaraldehyde. The stent is about 6 mm in length, and actually you go in from inside the eye and you inject it subconjunctivally, as you can see it. Once it is injected, the gel actually stents across the internal aspect and comes subconjunctivally without actually making any surgical steps involving the conjunctiva. You can see the bleb elevation there. So this is the Zen implant. The other one which is showing promise is called the PreserFlow, the InFocus microshunt. It is done from the outside and is somewhat similar to a trabeculectomy, which does seem to show promise. And we all have to look at what is the future of such kind of devices, or whether it will really help us Because cost is a big issue as far as the Indian scenario is concerned. We can't apply all of the MIGS in our practice. The surgical decision making as far as glaucoma severity is concerned, initially we would all start off with generally with pharmacotherapy, mild medication, mild glaucoma. Some of us would consider laser trabeculoplasty, SLT, and so on. MIGS can be considered when you're having mild glaucoma and the patient does not want to use medication. But MIGS can also be combined with cataract surgery in mild to moderate glaucoma. But for the advanced glaucoma, you would not expect the MIGS to be effective. So you would actually have to consider trabeculectomy with or without mitomycin, and also consider what we call as a tube shunt procedures like glaucoma drainage devices, absent glaucoma valve, or the bivalve type of implants without the valve and so on. I'm not talking about the implants in the interest of time today, but these are the options reserved for the severe disease. And disease is not responding to usual treatment. A word about cyclodestruction before I finish. If you want to destroy the ciliary body in patients who have refractory glaucoma, uncontrolled pressures, despite everything else you do, you have been considering cryotherapy in the past. Ultrasound had been available, is available in certain centers. The diode laser is the one which has the best combination of effectiveness, portability, and ease of use according to the American Academy. And most of us would use, in the past, we were using the diode continuous wave, and now we use the micropulse diode laser. The difference between the continuous wave and the micropulse transscleral cyclophotocoagulation has been that the G probe of the continuous wave will be applied in spots like this, and there's some gap between spots being applied. We would generally not do more than 180 or at the most 270. Whereas the newer probe with the micropulse, you can actually do a sweeping movement like this, avoid the 3 o'clock and the 9 o'clock, and you can actually do in most patients both above and below. You don't have to restrict yourself. And in the eyes with seeing potential, also the micropulse CPC cyclophotocoagulation is useful. This is the duty cycle of the micropulse, about 31.3%, with an on time of 0.5 and an off of 1.1. How does the micropulse work? It's supposed to be a subthreshold cell damage at the level of the pigmented ciliary epithelium with no visible scar. The avascular outflow increases through the remodeling of extracellular matrix, possibly considered to be a pilocarpine-like effect. I think I will stop here in the interest of time and take any questions if you have.
Thank you so much, sir. It was very engrossing. I think the short video clips really helped. And you just wrapped up a very comprehensive glaucoma session. Does anyone have any questions? I think no, not right now. Thank you very, very much, sir.
Thank you.
Yeah. So our final speaker for today is Dr. Preeti Naveen. She is a senior consultant in the Department of Cornea and Refractive Surgery in our hospital. She heads our DND and fellowship programs and is the director of the Dr. Agarwal's Eye Bank. Over to you, ma'am, now. Ma'am?
Am I audible?
Yeah, you're audible now and we can see you.
That's right.
Okay, and my screen is also visible, right?
We can see you, ma'am, but you haven't started sharing your screen, I think.
I think I've started because I can see it. Just a sec. My screen is now, you're not able to see my screen share?
Madam, no. Any error will come, madam.
Enama?
Any error? Error varda?
Error varla, but I've started screen sharing. I don't know why it's not coming.
Or share your presentation to Ravi, Preeti.
Should I just log out and log in again, maybe?
No.
No.
Send an email of your presentation to Ravi.
Just a sec. Just a sec, I'm so sorry.
Madam, share screen.
I request the participants to be a little patient. Please don't leave.
Yeah, we are able to see.
So I'll be covering two topics today. I think the one that Dr. Namrata was supposed to cover on keratoplasties and on PDEC. So I'll try to make it fast in view of time. So what exactly is keratoplasty? Keratoplasty, as we all know, is a procedure where we transplant the cornea to replace a deceased host cornea and with a healthy donor cornea. So why do we do it? The main objectives of doing the procedure are to establish a clear visual axis, to minimize refractive error, provide tectonic support, and for pain relief, and to eliminate the infection. So this is just a schematic representation to show you the different types of keratoplasty procedures we have. We have the traditional PKP, which is a full thickness transplant where all the 6 layers of the cornea are transplanted. Then you have the DALC, where only the anterior layers which are affected are transplanted. And you have the endothelial keratoplasties, which are the DSEC, which is a Descemet's stripping endothelial keratoplasty. Then you have a DMEC, which is a Descemet's membrane endothelial keratoplasty. And you have the recent ones where PDEC, which is a pre-descemetic endothelial keratoplasties. So in your endothelial keratoplasties, the primary layer which is transplanted is your DM, your Descemet's, your endothelium. And in DSEC, you have a part of the stroma also being transplanted. In DMEC, it is just the Descemet's and the endothelium, which is the thinnest transplant which can be possible. And then you have the pre-descemetic endothelial keratoplasty, which came into vogue and was started by Dr. Amar Agarwal after the discovery of the Dua's layer by Professor Harminder Dua. And so it gives an additional layer to the Descemet's graft, which is the Dua's layer, which gives an added splinting effect to the graft. And I will be talking in detail about PDEC in the later presentation. And you have our keratoprosthesis, which is indicated in patients in whom we have a high risk chance for a PKP and multiple graft failures, high vascularization rate. Those are the kind of patients you would choose to do a Boston keratoprosthesis. So when you look at penetrating keratoplasty, like I told you, it's a full thickness replacement of a deceased tissue. So what are the indications? So any pathology which involves the entire cornea, all the layers of the cornea, like full thickness scars. If there is a perforation which cannot be sealed by glue or a Tenon's graft or any other procedure, then we go in for a full thickness transplant. Herpetic scars, again, depending on the thickness and the depth of the scar. And vascularized scars and keratoconus. So keratoconus, I would say DALC in most advanced cases, but in cases where you have scarring post a high drops or stromal scarring, then in those cases, we would prefer to do a penetrating keratoplasty. So some of the indications, like you have them as optical. So optical indications are scars. Again, you have dystrophies and degenerations, congenital corneal opacities, and keratoconus. Those are some pictures on the side of dystrophies and degenerations, which you can see. And tectonic, again, is where you want to restore the integrity of the eye. That is where we do a tectonic graft. And in cases of a corneal perforation or thinning, and that's a picture of an eccentric tectonic graft, which was done for a peripheral perforation. And therapeutic graft, as we all know, any case of a non-healing corneal ulcer, which is being treated initially with a medical management, and still there are no signs of resolving, then that's when you consider a therapeutic graft. So this is just a picture of a post-PK patient, where a full thickness transplant has been done. You can see the sutures in situ. And I would be showing you a couple of videos of all these procedures. So let's just finish this. So then going on to lamellar keratoplasties, where I mentioned that you will be removing only the particular layer of the cornea which is affected. So you have anterior and posterior lamellar. So anterior lamellar is superficial, then you have a mid and a deep lamella. Posterior would involve your DSEC, your DMEC, and your PDEC surgeries. So common indications for lamellar, again, are dystrophies, which are most superficially placed. And so one most common thing which you'll all have to keep in mind is how would you evaluate a patient coming in for a corneal transplant? So first and foremost, you will have to assess the visual potential of the patient and with the best corrected vision, the uncorrected vision. And if there is a disparity, then we have to go for a contact lens trial in these cases, just to make sure how much of vision potential the patient has, and to just rule out if they're amblyopic, to give them a guarded prognosis, or in cases where you feel that with contact lens the vision is improving, then you know that post-surgery the vision potential is possible in these patients. And also to explain to the patients what to expect out of the surgery. So you can do a RAM also in certain patients where your vision is not corresponding to the level of issue in the patient's eye. And so again, so that's with regards to the vision. Then ocular surface is something which is very important, and we tend to miss out the nitty-gritties of this before we take in a patient for a penetrating keratoplasty, or any keratoplasty for that matter, because the healing and the prognosis totally depends on multiple of factors. So patients with dry eyes or blepharitis, trichiatic lashes, exposure, ectropion, entropion, these are some things which you would want to correct prior to your surgery, because the post-op visual outcome is much better if these are treated prior to the surgery. And again, the intraocular pressure is another main important component you'll have to keep in mind, because post PK, some of them would develop a IOP spike, then they would be steroid responders. So all those are factors, because you start them on topical steroids. So you have to make sure that to start off with, their disc and their intraocular pressure, glaucoma evaluation and everything is on point. And so that if you need to combine a surgery like a TRAB or a glaucoma valve surgery along with the keratoplasty, you would be taking a very informed decision if you know these factors. Ocular inflammation should be recognized and treated prior to your surgery. And any patient with vascularization, again, vascularization is considered as one of the risk factors for a graft failure. So the deep vascularization involving more than 2 clock hours is again considered a risk factor. So you will have to document all these pictures. And I would say the best thing to do is, maybe if you have access to a slit lamp photograph or a photograph on your phone, just to document how many clock hours. And if there is too much of vascularization, you can always consider procedures to reduce them, inject anti-VEGF agents or a fine needle diathermy to these patients, and wait for the vascularization to regress before you jump in to do a keratoplasty in these cases, because it makes a hell lot of a difference if vascularization is under control. And again, you will have to get a proper history, because if it is a herpetic scar and if it's a neurotrophic cornea, then again, your success rate also depends on treating these prior to that. So if it has to be, you would have to start the patient on an antiviral prophylaxis pre and post surgery if you know it's because of a herpetic cause. And if it is a neurotrophic cornea, then we'll have to keep in mind about post surgery healing of the epithelium. So then you would consider combining the surgery with maybe a temporary tarsography till the epithelium gets better. And so there are multiple factors you will have to keep in mind before you do a procedure on these patients. And so coming to DALC, like I told you, it's only the transplantation of the anterior layers of the cornea, whichever is damaged. And the most common and successful surgery doing DALC is for keratoconus, which has the highest success rate. And in this procedure, basically, only the anterior part of the cornea which is affected is dissected, and then the donor graft where the descendants and the endothelium is stripped off and it is sutured onto the cornea. And so indications for DALC would be any patient with a healthy endothelium. So keratoconus, any anterior scars, dystrophies, and eyes at a high risk for endothelial rejection, like, a pellucid or a keratoglobus, you would want to do a large thickness tuck-in lamellar keratoplasty initially, and then maybe a central PK at a later date. And it's with Down syndrome. So the advantages of a DALC are, one is it is not a full thickness surgery, and the chances of endothelial rejection are less, and also the visual recovery is much faster in DALC. Some of the indications for DALC, like I told you about dystrophies, there's a post hydrop scarring, and then you have an anterior stromal scarring. This is a patient of a post-DALC surgery where you can see there are two types of suturing techniques here. You have an interrupted as well as a continuous suture technique. And these are some indications for a corneal ulcer and a case of a pseudophakic bullous keratopathy post-PDEC. And just a sec. So that was one presentation. So let me go to my video on PK surgery. So this is a case of a total leukomatous opacity. So whenever you consider doing a PK procedure, first is obviously you will have to measure the thickness. And in this case, what we are placing here is something called as a Fleringa ring. So that is a caliper just to measure. And you have a Fleringa ring. So the significance of the Fleringa ring is...
We're not able to see your video.
Yeah, we are not able to see the video. We are able to see only the thank you slide.
Oh, one second. Okay. Not coming.
Doctor, you opened the video, automatically play, doctor.
I opened it, ma, and it's playing for me. So I'm wondering why it's not playing for you guys.
Share the screen again.
Yeah. I am. Now, can you see? Can you see it now?
No.
No.
Should I, one second. I'm so sorry for this. Can you see this one?
No.
The presentation. Just a second.
Preeti, able to see the PDEC?
Okay, you're able to see this, right?
Yeah.
Okay, super. So I'll probably go to this and then I'll put the videos at the end.
Minimize the presentation, then we open the video, doctor. It will automatically.
Yeah, okay. So PDEC is, like I told you, it's a posterior lamellar keratoplasty surgery. And I think we've already gone through what is DSEC and DMEC. So PDEC is basically where only the duas, the decimates, and the endothelium are transplanted. And the advantage of PDEC is, one is it has an added duas layer, which gives it an additional splinting effect. And the normal decimate endothelium complex would be around 10 to 15 microns, and your PDEC would add on another 10 to 12 microns to it. And the another advantage is, one is your donor age. You can harvest it from very young donors, which is not possible with DMEC. And the advantage of taking a young donor is, again, you have a specular count, which is very good. And so that's one of the major advantages in a PDEC surgery, where you get to work with a good specular count in these cases. And the indications would be same as any endothelial keratoplasty: Fuchs, posterior polymorphous, CHED, and pseudophakic and aphakic bullous keratopathy. And contraindications would be something where I wouldn't want to do it in certain cases where there's too much of stromal scarring, deep level stromal scarring. And so PDEC is basically the inverse of a DALC bubble, I would say. And you have two types of bubbles. Generally, you have a type 1 bubble where you separate. Yeah.
Sorry, but your slides are not going. It's just on the title slide.
Really, it's moving for me. Oh God. Now, is it going now?
Doctor, please select for the enable editing. Then only. Enable editing.
Enable editing.
Yeah, so productive, select for the enable editing.
1 second. Can you see it now?
No, doctor.
It was moving initially, and then, yeah, now, yes, it's moving.
You're able to see now?
Yes.
Okay.
You're in the type of bubble.
Yeah, okay. So your type of bubbles, like I said, a PDEC bubble is a type 1 bubble, which is typically separating your stroma from your duas, decimates, and endothelium complex. And it's something that starts in the middle. And I'll show you a picture. Here you can see this is the formation of a type 1 PDEC bubble. In your figure 2, your figure B, this is where you see this is a dome-shaped bubble which starts in the center and extends towards the periphery. Typically, it is around 7.5 to 8 mm in size. And this is something which shows the other types of bubbles. So you have a type 2 bubble, which is a DMEC graft actually. So it starts in the periphery and starts progressing towards the center. And the figure D, which I'm showing, is a complete type 2 bubble, which is formed. And then you have a mixed type 2 bubble, which is forming in the periphery, these small type 2 bubbles. And then you have a mixed bubble where you have a type 1 in the center and a type 2 forming in the periphery. So a PDEC bubble is something which is a type 1 bubble, which we would harvest. And so I'd go on to surgical steps. So basically you have a PDEC bubble graft, and you have to incise the bubble, inject the Blurex dye, and cut the graft according to the size you need it. And I think I would skip all this and just go directly to the videos so that I could explain it better there. And PDEC in special situations are usually before you start any keratoplasty or endothelial keratoplasty procedure, we would like to make sure the other parts in the anterior segment are settled well. So if there is an aphakia, then you would want to put in a gludial. And if there is a irregular pupil, you would want to make an SFT so that, when you inject your graft, there is a proper platform for it to settle in, and before you put in air to fix it to the donor cornea. And PDEC and failed grafts, sometimes when we do therapeutic keratoplasties, instead of going in for a full thickness cornea transplant, we would prefer to do a PDEC cases. It has the added advantage of not doing a full thickness transplant again. So the problems with a PDEC graft is intraoperatively. Sometimes if you fail to get a type 1 bubble, you would want to convert it into a DMEC. Or if there is a burst in the bubble, if you take a smaller graft, or if there is a reverse graft unfolding rather than the correct side, and poor graft visualization. Postoperative complications, immediate and late, would be a graft detachment, DM folds, folded graft, or the loss of air bubble. And late ones would be graft failure, rejection, interface haze, and iolopacification. And post-operative care, again, would be usually typically after any endothelial transplant where you put in air. We would advise a patient to lie in a supine position so that the air is able to hold on to the graft. And post-op day 1, a digital IOP is checked, obviously not an applanation, and an ASOCT is done just to make sure the graft details are noted and the graft is well attached. And patient is typically started like any keratoplasty post-op. We would start them on topical steroids, which are slowly tapered over a period of 6 months to a year. And these are some of the pre and post-op pictures of PDEC surgeries. This is an indication for a pseudophakic bullous keratopathy, and most of them are PBKs. This is a case with vitrectomy and SFT and where a PDEC was done. And this is a case of an ACIOL where if there is a case of an ACIOL, we would always prefer to explant it, put in a glued IOL, secure the iris with a single pass 4-throw pupilloplasty, and then go ahead for a PDEC surgery. And this is a case of a PDEC being done in a therapeutic graft, which is a failed therapeutic graft. And typically after 3 months after the surgery, we plan the procedure where we do a cataract along with a PDEC in them. And so I think I'll share my videos. Just a second.
Preeti?
Are you able to see my video?
Yeah.
Okay. So I'll just finish in 2 minutes. This is just a video of a PK where we're putting in a Fleringa ring. So the flaring indication, the main indication for a Fleringa ring is you want to maintain the scleral stability where you have in pediatric cases or in vitrectomized eyes to maintain the scleral rigidity, we put in a Fleringa ring. And after you measure the donor cornea, usually the host cornea is measured and then 0.5 or a 0.25 mm more is taken in the donor cornea. And once you secure the Fleringa ring to the patient's eye, and they have different sizes. So based on the cornea's scleral diameter, you could take in a Fleringa ring of any size. And so this is using a manual trephine. We do have suction trephines as well. So you do a partial thickness trephination, especially when it is a leukomatous eye, when you're not able to see the anterior segment details. Please don't go full thickness because you don't know what's underneath, you would be damaging a normal lens also. So take in a partial thickness, enter inside, gently inject visco and try to open up the graft using corneoscleral scissors, your right and left or a universal scissor. And once you're inside and you have a fair idea of what is inside, whether it's a phakic or a pseudophakic patient, so we would trim away the edges, and I'm just forwarding the video. So once that is done, you take the donor cornea, secure it onto the patient's eye, and we use ninoethalon sutures. So 16 sutures are placed, the 4 cardinal sutures, and typically they should form a rhomboid appearance once you're done with them. And your cardinal sutures can always be replaced at the end. So you have to be fast while you're doing your primary suturing because you don't want an expulsive hemorrhage on table. And then you have your 16 sutures which are placed. And once it is done, you can check with a keratometer intraop just to check your astigmatism, and remove the Fleringa rings, bury the sutures, and that's the end of a PK surgery. And just make sure that you wash out the visco completely, because post-operatively, most common thing is visco retained in the anterior chamber, and that causes an IOP spike in these patients. I'll just share a PDEC video with you. Just a second. So this is a PDEC, which is simplified probably in 15 steps. And I think this is how we, this is a video showing how the PDEC bubble is being made. So you use a 30 gauge needle with a 5 cc syringe. Am I audible and is the video visible, ma'am?
Yes, yes, yes.
Okay, super. So we use a 30 gauge needle with a 5 cc syringe. We inject inside and we get a type 1 bubble. So the plane of the injection is very important, because otherwise you would end up perforating the graft. And once you get a typical type 1 bubble, we just try to enter the bubble with a side port knife. And we would initially try to inject Blurex at this phase, because we try to do double staining. So we do it once now to know the margins of the graft more clearly while you're trying to dissect the graft. So trypan blue is injected so that the edges of the graft are stained well before you try to dissect them. So there are two ways of dissecting the graft. You could either use a Vanna scissor to cut them around, or we could use a trephine to punch it. And this is a case of a pseudophakic bullous keratopathy with a little anterior scarring, which is mostly an epithelial hypertrophy, which was checked on ASOCT. So before we start the surgery, we put in a trocar maintainer, mainly for a continuous infusion in the eye while you're doing the other steps of the surgery. The advantage of a AC trocar maintainer, it has a very snug fit. So that's why we prefer to put that in. And that is connected to saline initially to start off with. And most cases, if there is no pre-existing PI in these cases, we try to do a surgical PI at a 6 o'clock position. The reason being, you want to prevent a pupillary block occurring the immediate post-op day because of the air which you're going to put in. And once that is done, you put in 2 side port incisions, temporal and supratemporal and nasal, but it could vary based on your location, your feasibility, whether you're a right-handed or a left-handed person. And so you can see us scoring off the decimates there. The decimates comes off pretty easily. So if you're having certain amount of resistance, it means you're pulling out the duas there. So just be careful about that. And once you've stripped out the entire decimates, we just put in a main port entry just to remove the stripped off decimates from there. And so the light which you see over there is an endo illuminator. So it is used for better visualization of the procedure. And it's something called as an EPDEC, which was started by Dr. Susan. And so you can see an inferior iridectomy being done in that case. And so this is a graft which is being loaded into an injector. It's a Zeiss IOL injector. You could use any IOL injector of your choice. Just make sure you remove the plunger, because we don't want it to damage the graft. And once the graft is put in, basically you have to make sure the scroll is right. It always scrolls towards the stroma side. So once you're sure of the scroll, and we switch off the air pump, because you want the chamber to be shallow while you're injecting the graft for it to unfold easily. And once you load the injector, put the graft inside. The first step would be to suture the main port, because during any manipulation, you can expect the graft to come out. So the endo illuminator again helps us in identifying the side of the scroll. If you can see the edges, they are scrolled inwards, which is the right orientation of the graft. Because we don't stamp our PDEC grafts, we could do it, but since we have the endo illuminator, we don't do it. And so once you're sure of the direction in which the graft is, you put in a little air bubble. So if you can see, there are still certain folds at the periphery. So the advantage of PDEC here is you can see the easy manipulation in which we are trying to push the graft, pull it around. So that's something which you can't do with a DMEC graft, because it's very thin and the tissue tends to tear. So it's you put it in and just have to float it up. But with a PDEC, you have an advantage of manipulating the graft like this. So once you feel the graft is in place, then we put in an air bubble to secure the graft. and all your side port, your main port, and all your incisions have to be sutured. It has to be an airtight wound so that the air stays in longer in the patient's eye. And this is a pre-op and this is a 1 month post-op. So PDEC results are very promising, and it is a very advanced surgery which we do now. And it can be done in all kind of patients, especially very beneficial in failed PK patients where we don't want to do another large graft in these cases. So sorry for all the glitches which I had. Something was wrong with my system, and thank you so much for the patient hearing.
Thank you so much, Preeti. It was a wonderful session with beautiful videos, and you made it look really easy.
Thank you, ma'am. Thank you.
So today is the last topic is over. So we'll meet on next Saturday with the second day of Kalpa. See you all till then.